All right. Sorry for that. We were on the practice session only. And now, after I finish scanning this, I would make my uh, computer managers as a co-host and they can manage that. So then that is the stomach and aorta, and I see that this is a clockwise rule. I expect that uh, heart should be present caudally. I move the probe caudally and I see the heart, so I'm happy. The situs is confirmed. LV is on, or the heart is on the left side. So both conditions are met. And then I look at the four-chamber view and I see something here. And you guys, there have been some issues that many people would call this structure as some partition in the right atrium. This is actually eustachian valve. You, so this is actually eustachian valve. I'll run the cine again. Okay. So see this is a eustachian valve. Okay. So that is for this, and then uh, for a good cross section, you have to have uh, the ribs, which are, the entire ribs should be seen properly, and that proves that you are on the proper cross section. As the heart is horizontal in the fetus, you'll get a four-chamber view here. A very nice, not a very nice four-chamber view, but we'll try from little different angle, and we'll be able to. Yeah, so that's okay. Then we color Doppler, we were on a low PRF setting. I increased the PRF and velocity is right now about 64, and you see the things nicely. Okay, and one request was to show the DV, which I would show you again. Then this is the left ventricular outflow tract. Okay, and it's not seen fully. So what I do is I go cranially and I rotate the probe clockwise, and I'm rotating the probe clockwise. I'm going cranially. I see this an aorta in a bigger length. I would do it side by side. Now you see the aorta in a one-third of the ascending aorta. That is by clockwise. In the same position, I'm moving to more cranially, and I get uh, the RVOT view. So I put the pulse Doppler here, and I can see the RV outflow velocities, and with the opening and closing clicks. And somebody yesterday pointed out that closing clips are far better visualized, and I think that's absolutely right. And uh, uh, applaud for that gentleman. And he said only closing clicks are seen better than the opening clicks. So that's absolutely right. Here I see the three vessel trachea view, all looks okay. I reduce the Nyquist limit to look for the SVC, and then I want to hunt for the URSA. So I don't see any URSA here. And I see then the vessel which is going anteriorly from this is a normal left right subclavian artery. Okay, so there's no URSA. Look at the Nyquist limit, what we have done, 17 centimeters. Then with the same Nyquist limit, I come down and I try to look for the mm, so like look for the DV again, that you wanted to see the DV, and then there's a DV expected that you should do it in a sagittal view to rule out the DVSS or where the DV is entering. For me, this is okay. I just do the DV in any view, and I get the DV, and I'm happy that the DV flow is okay. Okay, so not let's not spend more time there and the DV, and let's go to uh, this is we're hunting for the pulmonary veins. So do you see one pulmonary vein? I increase my balance. I reduce my wall filters. I reduce my Nyquist limit slightly further, and then I do little more optimization. I go to line density, ensemble, and then I may increase the smooth also here. Then I see a very nice uh, uh, reduce the 2D gain. I want to see more of color. And you see a very nice pulmonary vein. Put a Doppler there to confirm arteries always somewhere around and reduce the scale. And you see the pulmonary vein and pulmonary artery together. Okay, so now DV was done. That was one request. Second request was how to hunt for a VSD. Now let's do that. That as I think we should add that as a protocol into the screening guidelines and hunt for uh, a VST. So I would preferably go for the lateral view. So I've slightly moved my probe to a little different direction so that I get a lateral view. So there's a lot of shadowing from the top. Now it's fine. And then I actually go and zoom this area. And then here I put the color Doppler on and I keep the Nyquist limit high. Okay, to begin with, look for any VSD there. Now, in case you don't see the VSD, then what I do is I reduce the Nyquist limit. Okay. And when I reduce the Nyquist limit, you see lot of tissue being represented by color. So there was some doubt somewhere here that is there a VSD in this portion or not? We are not sure. What we are going to do is that we are going to slightly increase the size of the color so that we see it there. And then what I'm going to do is I'm going to reduce uh, the gain. Okay, so I'm going to reduce the gain. And when I reduce the gain, I want to see if there any flow which is going across. Now the septum is clean. You don't get too much of clutter there. The baby is moving. And there is still some suspicion of a VSD here, right? So let us confirm that again. Yeah. And we hunted and it is there. I mean, we were expecting this everything to be normal, and you see the bidirectional. You see some dropout here, and you see the VSD here, right? Done. The hunting has helped. And what this is on the side is not a VSD. This is pericardial. Small pericardial fluid is always present, and done, beta. All good. Thank you, beta. Hmm? No, we'll do it later. Okay, I think because we are on a side by side, so we will not get an award. We'll do it again. Yeah, please. So guys, so the all the three requests which were made yesterday, the third one is thymus, so we would do it in the next patient. I so I think that all the requests which you wanted to ask was answered. Ask me any questions, please.
Yes, good morning, sir. So,
Morning.
can you just point out the bidirectional flow in the VSD? Currently, we can see the red flow, that is one, and the blue, that one.
Yeah. That's what. So if you see the red flow and
Hmm.
then you see the blue flow, this is
Hmm.
bidirectional.
Okay.
Sometimes you see the red, now you see the blue.
Yes, sir.
Okay, now you see the red,
Yes, sir.
done.
So,
It's
what,
bidirectional. Huh.
like in 2D, we cannot see any.
Yeah, that's why we are hunting. That
Yes.
exactly what, and we've had just scanned this patient
Hmm.
cursorily in my regular clinic on the ground floor, and
Hmm.
we didn't pick up this VSD, and now we've hunted for it, and it is there. So if you are going to hunt for it, you are expected to see too many VSDs actually. But then again, I suggest please mention those VSDs only in the body and not on the top as a final impression, because this is going to create a lot of anxiety and a problem and maybe termination of pregnancies.
So, what I also wanted to know, do you measure the size of the VSD? is there any matlab ki postnatally any significance of measuring the size of the VSD when we measure in fetal echo antenatally, or is it just to for our
See, I tell
document?
you something, sizes are not very, very important. Let's say if a VSD is small or a moderate size, we know that hemodynamically when the child is going to be born, it's not going to be important. And anyway, we do understand the 70% of them would close when the child becomes about a year old. Then the problem is that we should mention large and not large VST. That is my take. But still, as of today, as per whatever small literature, there is very small literature on sizing of the VST in the fetus. Whatever literature says that it says that you can mention it as small, mid, and a moderate and a large size. And this literature is from the neonatal area, not from the fetus. And how do you say small, mid, moderate, and large is based on if the VSD is less than a third of the aortic annulus, we should measure the aortic annulus in these patients. And let me scroll up and down if I can do it here. Maybe something like this. We have an annulus, but it's not a true annulus. I would have focused there. But you can actually take a measurement of the annulus like this and see it is about 2 millimeters. And then I go to cine again and try to measure the VSD, because the color obviously overflows from the VSD, so it generally overestimates it. So let's take a measurement of the VSD here, and what we do here is that we take a distance, and that is what I would say is the size of the VSD. It's about zero point 0.9. So the aortic annulus wasn't calculated properly. The aortic annulus at this gestation should be around 35 mm. So in that scenario, it becomes less than a third. And if it is less than third, and we are overestimating this, okay?
Yes.
And if this is more than a two-third of or a three-fourth of the aortic annulus, then we call it as a large VST, or a 70% of the aortic annulus is a large VST, and 70% plus. And yeah, if it is same size as that of the aortic annulus large, and it can be larger than the aortic annulus also. So
So,
that is the best we can do. If you take a measurement here, the measurements are going to be very, very erroneous. So please don't take a measurement and mention the size of the VST. Just
so,
mention it small,
hmm.
moderate, or large. Yeah.
So another thing I wanted to know for hunting for VSD, it is just for muscular VSD, for inlet VSDs, and we'll just
Yeah,
see.
inlet VSDs are you don't need to hunt. Actually, it would announce itself by a dropout, and
Hmm.
you don't have to hunt for that, because
Hmm.
generally inlet VSDs are rare, and generally they are large. They are usually not small. I yet to see any small inlet VSD. They are generally large. Same applies for a perimembranous or a subaortic VSD. We don't see small perimembranous VSDs. In the fetus, we generally see a large perimembranous VSD. So that large perimembranous VSD would actually announce itself when you are doing a 2D scan by a dropout area. Now, applying the same rule of reducing the Nyquist limit and reducing the gain would not really be very helpful in the sub aortic area or a perimembranous area. The problem is that there we would have a normal pulmonary artery flow going behind the aorta, which tends to overlap it.
Yes,
Okay,
sir.
so then we may not be able to get good, this rule, as you rightly said, applies for muscular VSTs only.
Mhm. Yes, sir. Thank you, sir.
All right.
And sir, you are lowering the gain. You're lowering the color gain or the 2D gain or both?
Color,
Color gain.
color
Okay,
again,
sir.
color again.
Thanks.
Yes, anybody else, please? You guys just wait. I come outside for questions from our on-site fellows.
And so,
Hmm?
demonstration of atrial appendages, if they are seen, if
Ah,
it is
yeah, I
possible.
forgot that. Thanks for
Hmm.
reminding. I'll try to do it.
Thanks. Hmm.
Yes, guys. Yeah. Hi. So please keep sitting. Yeah, yeah. Tell me anything. So today I was a lucky day to begin. Hunted for something and it was there. And now you know how to hunt and how to see when it's there. We would put an M mode also on that and we'll show you. But I don't recommend that you should be doing M mode. Something when the because it transfers line, when the clockwise and anti-clockwise. I answered that Dr. Vijay is asking that if there's a transverse lie, then how do you? Now, in the transverse lie, you see the head is on either left or right side. When you are scanning, okay, you are not scanning. The probe is not like this. Your probe is like this cross section. Your probe is kind of vertical, and it's not probe is not horizontal, correct? And aligned with the, so it's actually sagittal of the mother, correct sagittal plane. So once you're in the sagittal plane, now you guys, you imagine this is the cranial and this is caudal. Where is the problem? Once you are doing this, you presume this is cranial and this is caudal. One is cranial, one is caudal. Agreed? So now you're scanning. Let's say if I see the clockwise here, okay, I expect the head to be down. And down is not actually mother's down. Down is actually on the left side. So I screen and see, and it's there. We never had any difficulty in any lie, but then you guys started asking, and then we started figuring, yeah, I should be able to give you some answer. So I figured out this is the answer. We never had any problem till date. We never. I find it more, robust that you're not dependent upon your imagination. You're not using any hand rule. You're not using an imagination. You're not imagining yourself in the uterus. You are not imagining, or you're not having a doll, and suddenly you're examining a patient and you see doctor is playing with the doll. So I think that doesn't make. For me, this works very well. I learned this from Dr. Suresh in Chennai, and they use this, and that's the first time I learned, and I was so happy that this works almost all the time. It's never failed me. By now, I would have done about 20, 30,000 of fetal echoes, and it's never failed me till date. So if the head is in the right upper quadrant and then in the left. Same, then you are oblique. Either you are horizontal, or you are sagittal, or you are oblique. Then oblique is same, up and down. Where is the problem? You just imagine the fetus, and based on your pro position, for your pro position, there is something up, there is something down. Forget about lie about the fetus. And let me tell you, lies of the fetus, when it's a horizontal and oblique lie, it is still more challenging to do situs with all other methods. Well, all other methods put together, this still is easier. The clockwise method, then the thumb rule. I don't know. I've never used that ever, but I use this only. Yeah, it looks like, it sounds and looks like. So that's why I adopted. And but like what I do is that when the babies settle it, the stomach should be on my left side. On my left. This is what it. No, I depend, but it depends, na, whether it's a supine or this thing. Why imagine? Why imagine? It takes. I told you, it takes. I think you continue that because it's no, no, perfect. I think I don't want to because I'm a cardiologist. So you guys are radiologist and you know how to do it and you've been doing it repeatedly. But we are not very comfortable in looking at the lies and this thing. And so we thought, why work our head into that? It's a radiologist job. Let them do it. So then what we I when I started using this, and this I found it very useful. And my imagination is not required. Okay, and there is no proposition also, which is not proposition specific. Whether you have this thing, you normally do it on the your pointer on the left side. We do it on the right side. But see, everything is fine. We have adult echocardiologists, those who do the echo from when the patient's left side, then some people do when patient is facing towards them. Some people do it with the right hand. Some people would do it with the left hand. Whatever you've learned, if you are comfortable, please continue that. But I think if you can attempt once or twice this method, and if you find it useful, how many times you tie the turban? Once in a day, or many a times twice in a day? Maybe many a time if you have to go somewhere, twice in a day, right? So how many times? Around 500 times in a year you would have tied your turban. I also do the same, right? How many years you've been tying? You imagine, right? Do we ever challenge with the way we tie the turban? We don't. We don't. That is the wrong practice. Challenge it. I do it. I'm suggesting. Challenge whatever you're doing routinely. That is, let me scan the next patient. And I thought in between the talks, I would give you a pep talk yesterday, like we had it on the medico legal. And I'll share certain, books with you which changed my life. Life. Okay. One of the book is the Toyota Way. The Toyota Way. This is the book written on the Toyota method, why Toyota became so popular that even it was better than General Motors. Okay. People, the General Motors told that why don't you get, they were outsourced, the volumes were large, General Motor from US. They outsourced this few of the cars to be made by Toyota in Japan. Okay. And immediately the population in the US realized the vehicles made in Japan was better than vehicle made in US. All automobile industry, Toyota Way is taught as a ritual. Everybody. What is Toyota Way? Toyota Way is challenge whatever you do every day. Make an improvement. We do it every day, whether chair has to be here, whether scanning has to be this. Yesterday, I told you I'm going to start a video consent. So that is an improvement. So 1% improvement is 365% improvement in a year. Nobody can catch you. Nobody can catch you. So make improvement. The second, what they say is the zero lining. Okay, what they say is that if you have a component, let's say a nut, bolt, or whatever, then plus minus 5, for example, is okay. They make 300 nut bolts, and whichever are 5% plus minus the standard deviation, that this is fine. Okay, they said no, this is not fine. Let's try to pick up the nut bolts or things which are as close as possible to the zero. So they found 100 of those were as close as possible to the zero, and discarded 200 rather than going other way around. Imagine if you add so many components with this. Okay, so that's a book, the Toyota Way. Yes.
As we going from umbilicus to towards downward, where is the proof signs indicator?
Either side. You and me are cardiologists, we keep it on the right side, we do it right side.
जी सर, बट अगर जो नॉर्मल से पहले
वो उधर भी करोगे तब भी वही रहेगा. You wanted to know about the clockwise and rule, and it would remain the same wherever you put the position.
दो पॉइंटर टुवर्ड्स
हम्म
जब नॉर्मल ये भी करें, इमेजिनिंग सर नॉर्मल
हम्म
उसमें पॉइंटर कैसे रखेंगे?
Pointer depends upon the fetus position. Your pointer has to be, once I'm doing a scan, the fetus, my pointer should be on the left side of the fetus. Left of side of the fetus, if the position is, you know, is a normal lie and then or on a breech, you keep it on the left side. And in case it's oblique, then you keep it on the, you just go and take the cross section. The position of the
मतलब नॉर्मल में स्टमक जिस साइड है, अरोटा जिस साइड है वो लेफ्ट.
आप जिस साइड पे आपका स्क्रीन का है ना, उसी साइड पे आपको रखना है. Wherever your screen marker is, marker tells you what? Marker tells you that this is the side which you marker is showing. This is the side of, so whichever side is your marker, your the probe mark also should go on the side. If you have to rotate it like this, you keep it on that side. Okay, and if it comes on this side, then your image is getting inverse. So it should not cross the 90-degree on the other side. I will discuss that. Maybe that's a very unique question. I didn't think about it, but let me, formulate an answer for that. Uh-huh.
Sir, if our appearance is changing with the whether the fetal head is depending for reduced position,
Huh.
so should not it also change in the oblique position depending on if the head is below C of lycus or above the umbilicus?
I think further than that, go back and try. It won't. I can say that much now. हाँ जी बेटा, please tell me. Scanning the second patient. कोई कंफर्टेबल बेटा, कंफर्टेबल हो, जैसा भी ठीक है, जैसा भी रखना ठीक लगता है आपको. So now we see this, the fetus, and you see the uh, head is now spine is anterior, or then we can move on to this direction to make it so basal four-chamber view. You can see the pulmonary vein very nicely right on the top. You can so increase the contrast or decrease the Nyquist limit. Then you can put the color Doppler there and see, look for the pulmonary vein. You see the pulmonary vein there. You got which one? Ouch. Okay. So now you can see the pulmonary vein, and do you see the pulmonary artery along with? That's the pulmonary vein and pulmonary artery. Pulmonary artery and pulmonary vein. Okay. So that again is kind of a DV look in pulmonary vein, and you see the pulmonary artery along the side. So that done. So pulmonary vein we've done plenty of times and effortlessly. So that is the fossa vallis you see. Okay, so this is the fossa vallis area. Fossa is generally very thin, may not be appreciated well on the 2D in all times. Let me take you to this, increase the Nyquist limit or so that I get this. And then there was a question how to take Doppler in this area. You go there, you increase the Doppler sample volume or sample size, and then you see both inflow and outflow here. And then you put the pulse Doppler in this position and take it. So you get a good, nice signal both from outflow and this thing, and then you can actually uh, uh, see this, the clicks. Now, guys, you can see the opening click of the mitral valve. Here, you don't see the closing click of the mitral valve very well, but that was an opening click of the mitral valve. And you actually reduce the gain to calculate the various measurements. I'm not going to do it again. And let me ask a specific question, hunt for the appendages. That's what somebody wanted to know. No luck in this patient, but maybe we'll try the next. Left atrial appendage is far easy to see because it's conical. It's a kind of an outpoaching, but the right atrial appendage is kind of merges with the right atrium, kind of seemingly. That's the right atrial appendage. If you can see, this is the right atrium, and that is the right atrial appendage. This one. So that is the right atrial appendage. It's a kind of a rounded structure. Okay, so that's the right atrial appendage. And then we go and try it, and maybe we'll try it some other patient. But I can tell you it's certainly very challenging to see the structure of the appendages. And I would honestly tell you, don't look for it. Done, beta. ठीक है बेटा. Okay. Yes, any questions, please? Right, beta. So if there are no questions, I think we move forward for the next patient. We just scan few patients, normal, abnormal. Yeah, get the next patient. And then maybe if time permits, then we would do a small short talks. Otherwise, if we continue to scan patients, oh, beta, please. So then we'll not be able to finish our theory part, which I think is important because we've reasonably scanned a good number of patients by now. कितने weeks है बेटा? So for the 2D, again, many times, guys, be very careful when you are examining. I'm going to show you something on the screen. Do you see this line? You see this line here? That means one of the crystal of the probe is gone. This line, the black. So if I keep focusing on that line, and I'll scan it and show you. Okay, and how to confirm that is look at this line. I keep scanning this side, that side. Okay, and this is the time when you need to change your probe. So that is kind of an artifact you should be looking for. Okay. Okay. So now here again, the abdomen, we'll just quickly scan this and zoom this area. Okay. So this is a kind of habit which I've formed over a period of time to just zoom and see it. And then on the 2D, you can see the structures. And again, it's the clockwise rule. You see the IVC, you see the aorta, and you see the stomach and the spine. IVC is on the right side, so which it should be. If both are on one side, then it is a juxtaposed arteries and it indicates uh, right isomerism. So now 2D gain is too much. I'm reducing the 2D gain. My Nyquist limit is too high. My gain is 85. So what I'm doing is reducing my Nyquist limit so that whenever I see the DV, I see a bit of an aliasing there. So if I keep this Nyquist limit down, I'll see the aliasing here. I immediately pick up this is the DV, and I now reduce the size of my sample, and then I look at the DV. So you saw that DV, and then let me show you the hepatic veins or something, so that you know how to differentiate between the two. Many a times you get hepatic vein and then you think it's DV, and that is how the hepatic vein looks like, and that's how, I think what fetus has moved, that's how the DV looks like. Okay. So now we move to the head is down, that we've confirmed that, and maybe let's do the hunting for, we are on the low PRF setting anyway, and you see then I put the, okay, and then I gradually reduce the gain settings. So now gain is reduced. Now I can look for a VSD. Many a times you do see few tweaks going up and down, but if they are not consistent, they generally are not a sign of a VSD. So again, go to the high Nyquist limit, and here I rotate the probe by about 45 degree and get a good LVOT view. You see this is a good LVOT view, right? So then I move the probe more caudally, because here cranial for the fetus, and caudal when I'm examining the fetus is moved to a little bit, but now that's, so then I get the RVOT view, and little better we get uh, the three vessel trachea view. So when the three vessel trachea view is there, you can see this is left SVC, the right normal SVC, this is trachea, and that is esophagus and pulmonary artery, PAS pass. Okay, then let's try to look for the thymus. We put the color Doppler off, and when you are looking for the thymus, it's a good idea to go to low dynamic range, the high dynamic range, so that you get better visualization of the tissue characters. And thymus, how to differentiate it from the lungs around, is that this had a different tissue texture than otherwise. So then do you increase your, put the color Doppler on, and let's see for the time being. Okay. And it has to be a true cross section again. Okay, something like this. All right. So and how do you take a measurement? You take a measurement of the thymus. You take a measurement from thymus from the anterior aspect of the aorta and to the chest wall. And then the second measurement you do is from anterior part of this, and oh sorry, we go to a distance, and then we take from here till the spine, and then we take a ratio of these two, and 0.4 is okay. Less than 0.4 indicates hypoplasia. Hyperplasia we are not very much interested in, but we are interested in hypoplasia, so that so then there are other ways of taking this which uh, was described, I think, by Devor, and then in that, let me see if I can do that. We should see the memory arteries, and this is where we are. We reduce the Nyquist limit. Okay, and maybe little more, or we can go to a pulse power Doppler for that. Yeah, we could see one, yeah, one memory artery here, right? And this is encircling the thymus, and then या प्रोब चेंज कर लेते, लेकिन आई थिंक लेट्स ट्राई विद दिस ओनली. हाँ वो तो हम्म. Yeah, see one memory, you see this memory artery here, okay? And then other one you saw it here, and in between the area is that of thymus. So this is what they call as a thigh box, and there's a nomogram available for the volume of the thigh box, but it has somehow not become very popular. We still follow that thymus and this thing because we just need a rough assessment of that. Okay, beta, normal. We have other patient to be scanned. How many you want? नहीं नहीं ठीक है, नॉर्मल है. ये नेक्स्ट वाले का. Yes. You talk when the patient comes. Okay. Any question, guys, so far? We'll attempt thymus in most of the patients, and then we see it. I have a distinct advantage of level 2 scan being done here. Anything, beta? आ जाओ बेटा, प्लीज कम. ये छोड़ दो, आप उधर से आ जाओ. मेरे को सारी डिटेल बता दी उन्होंने. I'll just scan that, you don't worry. पहले कुछ एक डाउट्स थे ना फ्लूइड के एंड दिस थिंग और फंक्शंस के, हार्ट फंक्शंस के. ठीक है, तो हम आपके फीटस के हार्ट फंक्शन चेक करेंगे और थोड़ा सा पढ़ाएंगे भी. राइट, आई होप दैट इज ओके विद यू. यही था. आई थिंक लो लो वाला थोड़ा बेटर था इसमें. So we are in slightly different setting, which is a low flow setting, which we've created a preset, and then again try to get the spine not like this when you see multiple ribs, and try to get cross section. Now you see a single rib, that means that you are at the true cross section, and whatever measurement you take is going to be okay. So what is the guys your first impression looking at this? Okay, I think there is a bit of an issue of answering that. Uh, okay.
LV appears mildly small.
Yeah, again, which one, egg or hen? Is it the right ventricle and RARV dilated, or is LV which is small? That is the question which has to be answered. I can answer that by doing a Z-scores here, but with experience, I know once the LV is forming the apex, that means LV is not small. When LV is small, the first portion goes is the apex, it doesn't form the apex. So if LV forms the apex, that means the RV is large. All right. So that is rule number one. The LV is forming the apex, and that means the RV is large, and we need to find out the reason why. And whoever is interested in the right atrial appendage can see the appendage on this side. It looks like just an outpouching of like you can see this is an appendage, and these are kind of pectinate muscles what we see in the right atrial appendage. Okay, so I'll run this cine again, and you see this is uh, the right atrial appendage. So we'll attempt left atrial appendage somewhere there. You see the pulmonary vein, and that's fine. And yeah, very nice flow in the pulmonary vein, not an issue at all. Okay, you see the left pulmonary vein, upper pulmonary vein, and the right upper pulmonary vein. And that's the right lower pulmonary vein, which is joining here, this one. Okay, so anyway, we are not focusing on pulmonary veins right now. So let us do this, increase the, so there we are. Then we have this, okay, and I think there is a bit more of smoothness. I'm going to reduce that. And and then I can see some small whiff of tricuspid regurgitation, not very sure, but you know, we put the pulse Doppler here and kind of confirm it if it is TR or not. Maybe small, very early this thing. This is what you are getting, but not convincing. So forget about it. So now RARV are dilated, and you see the fossa vallis is patent, and there's no restriction of the fossa vallis. That could be one of the reasons the RARV can be dilated. So we've ruled out that. And then we go to the situation where RARV are dilated when you don't have a very obvious cause. And then here you see the RV inflow also is fine. So that means it rules out kind of a ductal restriction of a severe variety. Mild still can happen. And then what we do is that I don't think so. We need to see the DV, but you know, DV might help in this patient. Let's try to figure out where the DV is. And because one of the reasons for dilated RA and RV could be and absent DV and that umbilical vein draining into the inferior vena cava or the right atrium directly. Uh, but I think I'll come back to that again. Maybe I'm not getting the right this thing. I'll go to sagittal later and try to figure out. At least it's not opening into the right atrium. So the RARV dilatation is unlikely because due to the DVSS shunt. Okay, so now you see a minimal pericardial effusion around, and up to 2 millimeter is normal, and it looks like 2 millimeter and less to me visually, but let's take a measurement here. Sorry. So we take, by default, it starts doing BPD. All right. So it's 16, 1.6 mm, which is normal. Pericardial fluid is okay. So that part is fine. And the RV is contracting well. And how do I know it is contracting well? I'll take a 2D sweep. Okay, I maybe I take another one for a nicer this thing. Go to zoom this area a little more, and I take this a clip of not so nice, but I'm just waiting for a good, slightly better view. Anyway, let me try it here and then show you whatever it is. Maybe we'll go to the other setting. That would be better. So maybe we go to this clip. We pick up this clip, and I'll just tell you basics. We'll go to some other setting and then do it. This setting is not okay. I put an anatomical M mode here, and this is what I see. I see the contraction of the right ventricle and the left ventricle. Where is right? Where is left? So I'm going to tell you that. See, you see this line is cutting like this. So something, whichever is anterior, this is the pericardial fluid. Very first thing what you see here, this is where this line is cutting, this is the solid one. And this is the pericardial fluid. You can take a measurement of pericardial fluid here. Where do you take a measurement of pericardial fluid? You take it in systole. Okay, so then I take a measurement here in systole. That is here. This is systole, this is diastole, this is contraction, this is systole. So I take a measurement here again during the systole, and see it's just about 2 millimeter, which is fine. So now here I can take the diameters of uh, the ventricles. This is the diastolic diameter, and this is the systolic diameter, and from there we can actually calculate the fractional shortening. Here you can see the RV is contracting wonderfully well. So it's not RV which is hypocontractile. So you have RV which is contracting normally, and what you have here is normal right ventricle functions. So that part is done. So right ventricle is dilated, but it has normal functions. So that's answer.
Sir, can you show the M mode little zoomed?
I would show it in a little better position. Let the fetus be in the lateral position, or I'll
And
try
then
to
show
acquire
it in
lateral.
diastolic function again.
So this would be a little better setting. So okay, then if it is in lateral position, it will be far better. More the angle of M mode, less is the resolution. So here we have to angle the M mode quite a bit. So that's what. So now the angle is about 90°. Okay. Right? M mode is okay now.
Yes, sir, but with lesser sweep speed.
We can. In case you are still not happy with the M mode, you join adult cardiology, because that's where you see it very nicely.
No, no, sir, just like zoom. Le-
Now you can
Can you
see it.
decrease the sweep speed, sir?
Pardon? Okay. Speed you can do whatever you want to do.
Huh, sir.
That's possible. You can make it like this. You can make it like this. You can make it like this. Okay. Are you happy with this? Then we go to this, and then we can reduce the speed. We can increase the speed.
Okay.
Okay.
Huh,
Now,
sir.
Sisley, Dashley, good. Done.
Yes, sir.
Done. You saved. You're not joining adult cardiology. Okay. Now we go to a 3-vessel trachea view. And what do we see here? We see how many weeks of gestation is that? Huh? 28. A lot of shadowing is there. Okay. Hmm. Are you okay, beta? Just थोड़ा सा पीछे आ जाओ. So that, yeah, it's okay. That's okay. That's fine. So I think beta सीधा ही ठीक था. It was better when you were right. Yeah. Maybe you turn on the other side. मेरी तरफ turn ले. Anything in the anomaly scan? Doppler parameters, everything is normal? Okay. So we go to a 3-vessel trachea view. We would attempt a couple of times because we're not getting a good window right now. But anyway, with the fetus would move, and then we'll be able to get it a nice window. But whatever we get, at least we should take. Now, what do we see here? We see the pulmonary artery and the pulmonary valve. Okay, so let us take, we have not entered the name. Can we enter the name right now and the gestation age so that we can do the Z-score? Positive when you do, then you enter the, okay, fine. So we have to have a gestational age fed in there. I'm not as smart as you guys are to take FL and circumference to calculate. Okay. So that is the pulmonary valve, and I'll show. This is the pulmonary valve, this one, and it has to open, and then we take a measurement. Now it's open. Now we take the measurement at the same place. We go to calculation, go to Z-score, and go to pulmonary short axis. We go to pulmonary annulus, and there we take a measurement here. Okay, somewhere here was the valve. and that is the measurement of pulmonary annulus, and the z-scores are almost fine. So based on the gestational age, now that's what the beauty of z-score. Z-score is a wide range. So, I mean, that can come in the normal range, but the issue is that you compare it with the aorta. The aorta is smaller than so the comparison is far better than uh, doing it otherwise. But here, if you see the aorta and the pulmonary artery, they are looking at almost the same size, so that's not very abnormal. And let's put the color Doppler on the pulmonary artery and see in case there is something else we are dealing with. The PA is not very grossly dilated, and you put the pulse Doppler, color Doppler on this, and you see the branches of pulmonary artery, and that is fine. I increase the Nyquist limit, and I see the pulmonary artery is fine. There is no elasing, but still, I can do a pulmonary velocity and slightly change the angle, and less than 100 p velocities, aorta and PA are okay. So nothing too worrisome. And what else? We have a slightly dilated SVC. I do not know the reason for that. And see, this is an SVC. The SVC should be smaller than aorta, but I think it's smaller than aorta anyway. So that also is normal. So it's actually, sorry, but I'm just loud thinking, right? So I autocorrect myself many a time when I'm thinking loud. Yeah, but that would be LV and RV ka bhi aa jayega, that can. Okay, so let us take a tie index here, and we do a pulse Doppler, and we forego the angle, and then we put, and we'll try to do it at as quickly as possible on the pulmonary valve. We just take 2 or 3 this thing and save it, and then we go to the pulmonary artery and take another one, and done. So we save both the here, and then what we do is that reduce the Nyquist limit, see both opening and closing of the pulmonary valve. And what you see small wave in the front of the pulmonary valve is actually an A wave which is transmitted from the right ventricle, which tells you that the compliance of right ventricle is poor. When the atria contract, it increases the pressure in the right ventricle and produces this A wave here, or a pre-systolic wave in the pulmonary valve. You can see very nicely the pre-systolic wave. What is the significance? I think for you guys, nothing. Maybe a research project or something, but forget about it for the time being. But that's just a finding. I just wanted to share that. Where do we go? Z-scores. Okay, stop. Then we go to calculations. We go to Z-score. What? Clear study. Fetal echo. Oh, acha, we didn't want to do the Z-scores. Okay, so then we want to go to tie index, and this is, they've written the right ventricle tie index. They've not written left ventricle tie index, but it means the same, RVOT tie index. Okay, and then we have A is B is the ejection time, and then we take this B from here to here. Okay, and then we go back and change the view. We have to stop this, right? Okay. And then we select the other image. Okay, and then we increase the speed here, and we reduce the gain here. Okay, and that is the closure of the mitral valve and tricuspid valve, and that is the beginning of this, and that's the closure click anyway, opening click. So we see the opening click and this thing, I'm reducing the gain drastically. So I am interested from closure clip to an opening click of, so we go to measurements again, and then we do the A, right? So we are here at the tip of the click, and then we go here at the tip of the click. Okay. So z-score is RVOT z-score is 0.347. So RV functions are normal. Okay, the global functions of right ventricle are normal. We still don't have clue why the RV and the PA are dilated. So then what we do is that we take the ratio of PA of the PA and aorta, and here I think we can take nicely of the diameters of okay, so you should know how to take the diameters also. So this is the valve is opened. Now this is the valve is closed. Before it opens, here is the end diastole. Yeah, this is the place where you take. Now this is okay. That's the maximum when the mitral valve, tricuspid valve is opened. Tricuspid valve opens before the mitral valve. That is again high-end stuff. So now let's take the measurements here, and we take the distance, and we take RVOT uh, diameter, RV diameter here. We take this RV diameter here, inside and to inside edge. Okay, at the mid this thing, and then we take LV diameter from here to here, and then we take the ratio. So I think you calculate the ratio yourself manually. What should be the ratio here? So the diameter of RV is 13 and LV is 10, and that is not more than 1.6 times. So that's less than 1.6 times. So 1.6 times, when you do not have a PA very drastically dilated, you have an RA-RV dilatation which is less than 1.6. The ratio between, I think that can still be passed on as a normal variant. But obviously, we need to follow up to look for any other issues which can crop up later. But as of now, things looking normal. The RV functions are fine. The RV diameter are not 60% larger than the LV, and you don't see anything in the pulmonary artery. And maybe we would like to see the Doppler findings repeatedly in case there is some growth restriction which is producing an RV dysfunction. Any comments and anything you want to add here?
Sir, sphericity index
Yeah,
will it help?
sphericity index is okay. I mean, the visually I see it, and I think you're right. Maybe it's looking more spherical for the RV, but you have obvious RA-RV dilatation. So I think then we were talking about sphericity index when you don't have something obviously present there. If LV and RV are either of them are dilated, they can make the heart spherical. Spherical is for subtle finding when everything else is looking normal. So I don't apply sphericity index in case I get some abnormality. Looks okay, beta. So what we do is that we do a follow-up. Okay. And maybe when was the Doppler done?
सर एक्चुअली मेरा आज भी हुआ सर आज और पहले भी हुआ 16 मई
Hmm.
16 में अलग
No pericardial effusion. अच्छा, okay. So वहीं पे follow up कर लो बेटा लखनऊ में. That is the best. अच्छा. So what we do is that we would see the fetus again after 2 weeks. है ना? Avoid Saturdays and Mondays. These are busy. Okay. Midweek, you can come anytime. Then you can take her number. And then what we do is that we would do repeat this thing after 2 weeks without charging you and write it on the top. For now, everything is looking all right.
So actually background is कि जो 4th month में ये pericardial effusion का सारा
नो पेरिकार्डियल इफ्यूजन नहीं है, पेरिकार्डियल इफ्यूजन नहीं है. That mild pericardial fluid is because of the right ventricle dilatation,
okay
and less than 2 millimeter we state as normal.
normal हो जाएगा.
Yeah.
Okay. Sure.
Concern is not pericardial effusion. Concern is right ventricle dilation.
Pericardial ही सारा चल रहा था मेरा मतलब उसी के अराउंड थी.
I know.
फिर मैम से कांटेक्ट.
Yeah. Please. So I think the RARV जो dilated है, it looks nearly all right.
कुछ ऐसा कंसर्न तो नहीं सर.
मेरे को नहीं लग रहा, अभी नहीं लग रहा, but I can't be 100% committal.
Okay.
But issue is that unfortunately, even if there is something, we have no medicine or something to do. It is just the concern.
It's a concern. Okay. बाकी सब नॉर्मल मतलब फिर.
That's the concern. We did our best,
Hmm.
but rest I think is with God. We can't be 100% sure. That's the limitation. But it reasonably looks like that things are looking all right. Right? Okay. आगे बेटा. So guys, I take a short break and come back and stay online. I'm not going to take a break more than 3 or 4 minutes. So there is an urgency in the clinic, so I have to handle that and come back. बस काफी है ना. Done. रिकॉर्डिंग हो रही है ना, अब वो रिकॉर्डिंग हम पब्लिक करेंगे तो इवेंट होएगा ना, कोर्स बनाएंगे तो. Hi guys, I'm back. Saturdays are busy and there's some clinical work, so uh, let's start scanning the next patient. हाँ बेटा बुलाओ नीचे से कहाँ गए हो आप बेटा आ जाओ अंदर यू कैन कम आज प्लेट इधर इधर one of you have to be here always okay so okay we are now back to work and scanning another patient and then so now I think what we do is that even in unzoomed view, you can see. Let's zoom it, improve the resolution, contrast a bit. And here we go. Now, can you guys hear me?
Yes, sir.
All right. So guys outside, you can hear me now? This is again abdominal view. We start with this. We reduce the 2D gain. We reduce the Nyquist limit. You see the aorta on the left. You see the stomach on the left. And this is anti-clockwise, right? So I expect the head to be up. So I move the probe up and there I see the heart and I'm happy. To be low flow, you can see the pulmonary vein entering, but I think I'm more interested in a four chamber view. So we go side by side always, and then you get a four chamber view, little lateral, and then this is a good place for a fossa vallis to be seen. You please look at the area. What are we hunting is a look at the area behind the heart in and then you always should be sure that the area behind the heart is okay. You reduce the Nyquist limit to see any azygos vein there. You look for a distance between the aorta and the left atrium. So that is the aorta, and you see the distance from here till here is smaller than the size of an aorta. So that means this distance is normal. It is not increased. I use visual. If I play able to place another aorta here behind the heart, I would say this is increased. So now I rotate my probe by and go cranially, and I see the LVOT view now. Put the color Doppler on and see this side by side. Remember, when you want to see 2D in a very nice fashion, side by side doesn't work. the frame rate actually drops. Look at the frame rate. Keep looking at the frame rate. Here the frame rate is less than 50, is 49. Okay. So let's say if I put the color Doppler off and I just see 2D, the frame rate is 55. The frame rate has improved. So putting on the color and looking at side by side, the frame rate is lower than in case you are just interested in. So again, the right atrial appendage. Okay, the right atrial appendage, I'll run the cine for you. Okay, the right atrial appendage. All right. So then go back to the live scan. And try to figure out the left atrial appendage. And we would show you certainly, but normally left atrial appendage is far easier than the right one. But paradoxically, another way of looking at the left atrial appendage is look for the left upper pulmonary vein, and then the right atrial appendage is just next to it. So I reduce the Nyquist limit to look for the pulmonary vein, go side by side this, and that's the left pulmonary vein, upper pulmonary vein. So I'm not seeing it very clearly, but this should be the appendage. I'll just show you that. Okay. On the 2D, if you focus on the 2D, this is the left upper pulmonary vein, and there should be the left atrial appendage. It's not seen very nicely here, but anyway, we'll attempt it again. So you can imagine how difficult it is to look at the appendages. So let me improve my resolution, improve my dynamic range. Yeah, that's it. So now this is where the three structures are seen. So now these three structures are one. This is the left upper pulmonary vein. This is aorta, left upper pulmonary vein, left atrial appendage, and this is the Coumadin ridge. Okay. We'll see appendage in any next patient also in case we see it nicely. So again, the left atrial appendage. So that's the left atrial appendage. Okay, that's the Coumadin ridge. That is the left upper pulmonary vein. Okay, see that again. Now you see the left atrial appendage clearly. See that left atrial appendage clearly now? Okay, okay. So that's again the left atrial appendage, and then we go to three vessel trachea view. So that is where the three vessel trachea view, and it's all good. Okay, all good, clean cut. Now any questions? अभी नेक्स्ट पेशेंट नीचे करके भेज रहे है ना, या मितन को दिखा देना, मैडम को दिखा देना, कभी को पॉजिटिव होगा लेके आना, मैं भी क्लास लूंगा. So no questions online. Let me ask people whether on site. Yeah.
Sir, can you please show us extended view, that bicable view and aortic arch and ductal view in one of the patients?
So we would do it. So we would do it.
And sir, the sample report of fetal echo and
I
all the
forgot.
views.
I forgot. We'll do it.
And so one more question. When you do screening, how do you do check for two pulmonary veins, and in fetal echo do you see all four pulmonary veins or two is
I
enough?
try to attempt all pulmonary veins, but many a times it's challenging. And maybe I'd share you one article which
Yes, sir.
actually says that pulmonary veins can be abnormal in many situations. Normally, there are a lot of variations. Many a times, the left pulmonary veins join together and open as a single pulmonary vein. So there are no four pulmonary veins. You can have three pulmonary veins. You can have four pulmonary veins. You can have five pulmonary veins also. But there are normal variations, but our idea here is to rule out two most important things, and these are the veins we really look for. One is that we look for single vein, any vein entering into the left atrium, and if it is there, at least it rules out the TAPVC.
Yes.
Then second thing, what we look for in case there is the heart is shifted towards the right side, and in that situation, we do look for the right lower pulmonary vein, and we have documented one patient with the PAPVC of right lower pulmonary vein entering into the inferior vena cava, and that is what is called as Schmittauer syndrome. You can go to my YouTube channel, and there is one video on Schmittauer syndrome in fetus, and you can go there and see how do we angle our probe to look for the right pulmonary vein entering into uh,
IVC.
yes, and right pulmonary
Yes, sir.
vein normally entering into the left atrium.
Thank you, sir. And so as the person, then the extended views and all the views you do in a echo.
I generally
Uh,
don't do extended views. It's going to be a bit
okay.
challenging, but I'll do it for you.
Okay,
So
sir.
I'll
So
tell you the tricks how to get an aortic arch and
yes,
how to
sir.
get a pulmonary arch.
Thank you, sir.
Sir, in previous case, there was chamber discrepancy. So after 28 weeks, normally also there is some chamber
Exactly,
difference.
exactly. There is
So
that's
how
what I'm
to,
thinking. Hmm.
yes, sir. So after how many weeks we should pass it as normal chamber discrepancy, like it can be normal or physiological.
He after 28 weeks, if you do a scan, the RA-RV are normally dilated, and cutoff for saying it abnormal, as I told you, that RV should be 60 times 60% larger than, or the ratio should be more than 1.6. Below that, you can always know this is kind of a normal phenomena, and we've documented almost everything. The Doppler parameters were fine. There was no AV malformation or stuff anywhere. There was no ductal restriction, which we saw. There was no abnormality in umbilical vein. At least this was not opening into directly into the inferior vena cava, or it was not opening into the right atrium. These two DVSS shunts can produce volume overload, and we've seen there was no persistent left SVC. That's how you hunt for abnormalities in dilated RA and RV. So we hunted for all abnormalities and we did not find any. So now we are kind of rest assured this could be a normal variant. And maybe I've asked for a follow-up just for the reason that we might be missing something which we might pick up, and I don't know what. But I mean, it actually satisfies me as well as the patient that I mean, we put great effort to look for things.
Sir,
So let
sir,
me, yeah, please.
can you please show a probe manipulation once in camera actually? How to
Probe
make this
manipulation for.
that extended views and making the basic
I
views.
would show you, but I think the probe manipulations are again millimeter. You may not be able to appreciate that. I would try to do it, but still, I think me telling you that rotate the probe on this direction would be better because the rotation and everything is not very large. It's small. So I'll show you. I'll show you. I'll try to show you. Okay. Point noted.
So, just a follow-up to the previous question. When you are doing a fetal echo, you just do the axial views, and if there is an abnormality, then you go to the extended views, or
Usually.
yes, sir. And in a normal fetal echo, if everything is normal, then the axial views and
Hmm.
rest all that is taken, and that is all.
Yeah, yeah. I, I
Thanks.
I would think about any abnormalities missed in case I don't do sagittal views today, and maybe come back to you that. But one abnormality which was very nicely pointed out, that sinus venosus ASD would always be missed in a bicaval view is not seen. So we would start adding bicaval view at least in extended views, and ductal arch and the aortic arch, I don't think so. It helps me in any way. Uh, there was a patient and suggestion where there was a tortuous ductus arteriosus in one of the patients in the social media. The question was, what is the cause of a tortuous ductus? And that ductus was about 20 weeks. Usually don't get a tortuosity of the ductus at 20 weeks. You get it at late gestation because of the increased flow across the pulmonary artery. So then I suggested that you should do a sagittal view for the aorta to look for a tortuosity in the aorta, because tortuous arteries is a particular syndrome, a genetic disorder which should be looked for. So again, in there we looked for a thing when there is something was abnormal, but I think I would add at least bicaval view in that extended views of ISO.
Thank you, sir.
Sir,
So
in any condition, aorta can be dilated in fetus.
yeah, there are many. There are many. There is uh, one are the other pathologies present, like pulmonary atresia or a tetralogy of Fallot, or even in double outed right ventricle with a small pulmonary artery, PS, that is. So in that situation, you can have a dilated aorta. Solitary dilatation of aorta is known in a bicuspid aortic valve. We may not be able to see bicuspid aortic valve very nicely, but usually bicuspid aortic valve is associated with what we call as an aortopathy. There is some dilatation of the ascending aorta, and then you can have that dilatation. There can be an idiopathic dilatation of ascending aorta. I had one case where we did an autopsy and there was no other abnormality seen. So dilatation of ascending aorta is a disease which can be present. Marfan syndrome and those syndromes which produce aortic dilatation in children and adults, they generally do not manifest like a Marfan syndrome or something. They don't manifest in the prenatal period, though the case reports are there for Marfan syndrome to be presenting as a dilated aorta. So let me guys answer now the on-site people. I would have to leave this room and go out to answer their questions. Yes, please. Yeah. Any questions? Yo, there are. I think it's okay. I'll repeat your question.
इन द फर्स्ट केस सर जिसमें आपने मस्कुलर वीएसडी दिखाया था उसमें आपने एपिक्स में एक दिखाया था कि वो क्या पेरिकार्डियल फ्लूइड की
Pericardial fluid tha, and the pericardial fluid moves in different directions and produces a Doppler because of the movement, because that also is a movement, correct? And how do you recognize that? Now, once you have a diastole, when both LV and RV are dilating in diastole, it pushes the pericardial fluid towards the atria. So it goes away from the apex. So once you put the pulse Doppler there, or you on the color Doppler, you see the flow going away from the apex in diastole. And when there is a systole, that is the time the atria are dilating. Atrial filling is happening, and the ventricle is becoming smaller. So now the fluid comes back. So the flow in the pericardium is biphasic. systole towards the apex, diastole away from the apex. And that would be another help whether you want to confirm, but this doesn't happen in VSD.
ASD पिकअप करना इजी होता है
नहीं करना ही नहीं है, करना ही नहीं है, करना ही नहीं.
तो किसी ने मतलब रिपोर्ट्स में ना देखा वो ASD दिया हुआ है सस्पिशन ऑफ ASD
Up, you become smarter and tell them this is not possible. This is not possible. करना ही नहीं. Scundum ASD you cannot. Yeah, primum ASD and sinus stenosis I showed you, but scundum you cannot. Absolutely no.
Thymic hypoplasia हम look क्यों कर रहे हैं
आपका because 22q deletion, micro deletion, D George.
I am scanning normally और मुझे कुछ नहीं मिल रहा है वैसे
हाँ.
मुझे heart is looking completely
Yeah.
normal. So usually we don't look for thymic hypoplasia.
I do agree with you, but I think it's not a bad idea to look for that because in all patients of DiGeorge syndrome, you don't get cardiovascular involvements. There are facial, what is that called, fasciovelar syndrome or something. So that is some bony abnormalities and mental this thing. And so then you do it, but the thymus hypoplasia usually is glaring. Excuse, what do you see is that you see the aorta and everything moved quite anteriorly and it's adjoining that, and it would be an additional clue. You can suggest your geneticist to do a workup on that, and picking up the micro deletion is very easy. You can do it in 2-3 days time. What do you call that? No, with there were two techniques, karyotyping, and prior to that we used to do that fluoro. No. Anyway, that's not my area. Fluorescence, what you do is that fish, fish. So you can can be done very easily. So that doesn't take much time.
Can you show the bicule?
But we will do it. We'll do it. Certain areas I'm not very comfortable. I'll still do it. So this could be the first learning anyway. Hanji beta. Go.
It is a very absurd question, but
Go ahead. That's why we are here in a smart group.
it's more difficult.
Which one?
Adult echo or fetal echo?
Fetal echo is more, and adult echo has its own challenges. But many of we are thinking that adult echo is just looking for chamber size, regurgitations, and ejection fractions, but that's not true. A lot of development has happened in adult echo, and keeping updated on that is also challenging. Challenge in the fetal echo is the size. That is the only challenge. Challenge is size, and because of poor azimuthal or a depth resolution, what you get is that you get superimposition of the structures which are posterior and anterior. And that superimposition, adult echo is like 64 slice CT and fetal echo is like 4 slice CT. So that thickness issue is a big problem when the heart is small. And then a lot of things evolve. Missing a small this thing is a problem. Adult echo, they would recommend you in case the patient has some symptoms, ECG abnormality. Here you have no abnormality and you doing a fetal echo and you do 90 normal and get one abnormal fetal heart, and that is a challenge. That high risk that one also, if the findings are subtle, if you do not hunt for things or do a scanning in a proper protocol manner, you would miss it. So it's finding a needle in the haystack. But also that are the challenges about fetal echo. For both have their own learning, but I presume learning of adult echo is easy.
Will you recommend some radiologists to learn adult echo?
I mean, let me answer that question, and unbiased question, and let the people, those who are listening to me online, also enjoy that. I'm going to quote the book. As I told you, I would in between do it. The book name is Who Moved My Cheese? If you haven't read it, pick up and read it. You travel from Chandigarh to Delhi by Shatabdi, and you'll be able to finish the book there. Very small. Who moved my cheese? So I'm going to answer your question based on that. Now there are two mice, and there is a maze, and in that maze, one of the mice found cheese. So they were very happy. There's a large quantity of cheese. Both ate it very well, overate it. You never know. It's not there. It's the first discovery which they made. They overeat it. Then come back home, and the next day get up very early in the morning, right? Just to, so that nobody else sees, and they are able to eat it in case it's still there. They enjoy a lump sum. At this time, they don't overeat. They come back. Then they become lazy. They said, cheese is always there. Why get up early in the morning? We'll get up at 10 o'clock and we'll go comfortably walking, chatting, and have whatever we need to eat, and we'll come back. So they get up at 10 o'clock and 11 o'clock, and then this is business. This is how you approach your business, right? So then what do they do is that so over a period of time, they realize we are walking from such a far off distance here. Why don't we buy a house just close to that cheese station, and so that we get to get down and eat the cheese and come back? Again, business, right? So then this is what they do. And they are very happy. And again, the next step is business. One day cheese disappears. Okay. Now your business is gone. Then they blame God. We haven't done anything wrong in our life. Why this should happen to me? Why suddenly my number of patients has reduced? I have nothing wrong. I didn't do anything wrong to anybody. Why God is punishing me? Is that the normal reaction? So that is the normal reaction. Second, no problem. It must be a genuine issue. It'll come back tomorrow. Right? That's another. It doesn't come back tomorrow. Then there is a controversy theory that somebody has actually moved my cheese. There's something wrong somewhere. And out of these two, they keep cribbing. One of them decides, let's find cheese somewhere else. He moves on. The ideal group of mice are those who keep their shoes on their shoulders. Okay, the running shoes. They know that cheese would move someday or other. It is bound to move. It is supposed to move. Right? Only constant thing in life is variation. Right? So whenever the cheese moves, they move and leave that place, and they know the pattern that it won't come back again. They don't blame anybody. They say it's a normalcy. That is supposed to happen. And then they move ahead. And over a period of time, they realize the smell of cheese, the bit of texture of cheese tells you that it's going to move. Right? So they are prepared in advance. I hope you understand what I wanted to tell you in this story, the radiology. Now, radiology is, we are running through the era of an AI. Then you would have changes. Your business is likely to move. It won't disappear. It is likely to be moved, and you would be prepared. Okay. Now, back to your question that should you be doing adult echo also or not? My suggestion, in case you are in a tertiary care place like Chandigarh, Delhi, and Calcutta, in a big city, and you don't have to do everything. There are people doing everything. You doing echocardiography and a DM cardiology doing echocardiography, you would have an issues there. in future and today, your cheese is likely to move more quickly. So in that scenario, but in case you are working in an area where, people would prefer not to travel 20, 30 kilometers and would wish to get the thing done, you obviously would be a shade lower than a cardiologist or a physician, because he has a lot of knowledge about about cardiology, and you are strong in imaging. So then this is logical. If you are in a small place, not Karnal, I think you are from Karnal. So not Karnal, and then there are, various people would would get an ultrasound and this thing done to a place where you are not practicing, right?
Yes,
So
yes.
so then it's a referral kind of thing. They don't tend to lose the patient. If that scenario and you are not working in a big area or a space, that can be done. That can be done.
So do you think that going towards fetal medicine is better than doing cross-sectional imaging in the future because of the AI?
I don't think so, but I'm sure that imaging techniques which are like fixed, that is an X-ray, and let me tell you, AI can read X-ray far better than you guys can do it. Even memos, they can pick up far better, because this is just matter of pattern recognition. They recognize the pattern. Pickup of the tuberculosis and the nodules was far better with the AI reading an X-ray. There was an article which I was reading. So those static things like MRI, CT scan, CT angios, and X-rays are likely to be replaced by AI, but your role still would not finish. Your role is to, give your human this thing for AI, but the volumes would reduce. You may be reading 2 MRIs as you were reading 100 before. Okay, that is expected, very, very expected in a very short span. The most likely hit specialty would probably be psychiatry. There's no physical examination, there's no imaging required. It is listening and making the diagnosis. And in listening, AI is becoming very good. There are softwares which at least the Canadian government has provided all the doctors, that they can switch it on and it can recognize your language. It can interpret, and it'll jargon. It will take off. I went to that place, city, and then I went to that city. I had this. They'll just remove that and give you a discrete medical history. That is currently available, and they are doing it. So once that is the situation, fetal medicine probably would be the last. But AI is going to augment your fetal imaging for sure. There are two, three companies, one Medscape from China, and GE, and this Mindray. They are working very hard on AI. And not only that, if you take an image of a four-chamber view, it will show you green, orange, or yellow. But have you taken the good view? You're not taken the good view. So it is helping you, technician, or so he will help you till it is green. When it's the green, then it'll give you all the structures, all the measurements, all possible measurements on LV diameter, RV diameter, pericardial, this thing, mitral valve, sphericity index, you name it. On a four-chamber view, will give you all the parameters. That would improve your speed, and you'll be able to do more number. So that is a wild guess, but I think knowing more techniques is never bad. Maybe if you learn adult echo, it would complement you in a fetal echo also. So everything is kind of complementary. When I gave an exams of physics in ultrasound for ARDMS, I never knew the physics would come so handy to me. I never thought that, but it is. So it's a good idea, because now the things are getting fluid. medical plus engineering. There are in between areas, medical informatics in between areas, medical AI is something in between area, cardiology, fetal cardiology, radiology. They would have a mid path also. So in case you want to do adult cardiology, I don't think so it's bad, because you can learn, because you have plenty of time. You have plenty of time. You are not gynecologist or surgeon who is working late in the evening and for the evening calls. You can certainly learn all those things. Learning is always good. Don't stop that.
बट जैसे कोई ऐसा होना चाहिए ना सर जो एआई बेस्ड है जो आप रिकमेंड करते हैं जो अभी recently
Right now, don't do it. A lot of people are working on it. AI is something which decides economy of the country. Do you know India announced AI conclave in Delhi? Are you aware of that? Okay, there's nothing to do with this. This is all related with stock market. AI companies and the devices which are made for AI are going to direct the market. Okay, so yeah, so a lot of things are happening here. We now you use Chat GPT, you use Cloud A, you use Gemini, the 3 AI tools which I use frequently. And there are certain features which came, and there's another Manus. There are certain features which came in one AI tool. I mean, immediately the other guys copied it. Manus had a tool that you can give the command to the system, and you want to this topic, you want, let's say, fetal thymus. Manus is free. You can go Manus probably, and you can go on the Manus. You can get 10 slides free. You go and ask, make a presentation on fetal thymus. It'll give you 10 slides, and such a wonderful slide you have never seen. Okay, so 10 slides are downloadable. You download and do it. And now this feature is present in Capital, that is AI of Microsoft. Okay, so Microsoft offers you, when you're making a slide, it gives you so many other ideas on the side. If you are not updated, I tell you, the person, the NVIDIA CEO lady, I forgot the name, she made a comment that AI is a very fast moving train, right? But it's not for moving fast if you sit in it. Just ride. I use ChatGPT 4-5 times in a day. I use Google AI. I started that Gemini. Wonderful images. It gives you wonderful pics, and you can create your video clips. You can create a jingle. Tell it to create a happy birthday jingle for somebody. Tell the name and everything, it'll do it. And you would give them the style. You want it in Abba style, you want it in Punjabi style, or it'll give you a Pangra and then this thing. So ride on the train right now. Okay. I was in London, and I was supposed to travel from London to Birmingham. So what I did was I used ChatGPT. I put the video on. Okay. And I told ChatGPT, can you see where am I? Yes, I understand you are standing at the airport. So I said, I want to take a train to Birmingham. Would you guide me where to go? Yes, if you see on the signboard, it is writing that gate E, right? Follow that sign and go to gate E, right? You are on the road and you want to see what structure is this. You just chat GPT it and find. I found a kind of a small shit in my this thing, a rounded one, and I was scared that this could be mouse in the house, which is problem. I am only seeing the shit, but the mouse, that's what tells me. So I clicked it, asked the chat GPT, and chat GPT said it's now mouse shit. It is shit of a lizard. And how I recognize it a lizard, because there is a white tail behind that shit, and that white tail is actually urea crystals, because they don't have a urinary system to excrete urea. Okay.
So you were always very tech savvy, or like it's
No, I'm just riding the train. But I was tech savvy right from the beginning.
makes so beautiful diagrams and
Yeah. I love that. I love that. See, you have to choose your life. What do you want in life?
so
I was good in invasive, I've left it. My wife was good in gynae, she left it. I work from 9 to 3, and rest of time is all for AI and slides. I don't sit idle, and for learning. And honestly, I'm very happy that, yesterday we were discussing, I told one statement that I, in the last 1 or 2 years, I've learned adult echocardiography so much. This teaching course is not for you. This is for me. This is self. He knows the answer last time he attended my adult one. What was that? Self-inflicted CMEs. If I prepare a talk for you guys, I read 100, deliver 10, right? So if I don't get too many invitations for delivering a talk, so I create a YouTube, I deliver it on the YouTube, I prepare a talk every week. And about that topic, you can't challenge me. You can't challenge me on that topic, because I've read that in detail. Otherwise, how many times you open the book, how many times you go online for searching, you don't. So that's the best way.
Sir, what
All right.
tools do you use
So I
for your
think if we have a
presentation?
patient, otherwise we'll start with the talk. Pankaj,
Sir,
can we have one
hello.
talk? Yeah.
Sir,
Okay.
hello.
Come.
What tools do you
I'll
use for
introduce you.
your presentations? Sir, am I
Okay.
audible?
Yeah.
Hello.
Go ahead.
What tools do you use for your presentation, making presentation?
Right now I'm using my frontal lobe only.
No, sir, like PPT, AI tools.
No, AI, I don't use it. I use only AI for um, making some diagrams. In case you have seen my
Sir, that will great only I'm saying.
yeah, those pics which I take from the AI. Rest I don't do it. I do it myself. And I find AI to correct the things what AI has made would take a longer time. For I think beginners, it's a good idea. So maybe sometime down the line there is a request for asking for a help on how do we make a presentation, a medical presentation, and in case that webinar materializes, so we'll intimate you and you can join that webinar to know more.
Okay, sir. Thank you.
Perfect. Perfect. Same. Yeah. Naam enter kar do. You have that. So, guys, we are kind of printing the this uh, certificate. So, we'll give the certificate to our delegates, which are on site, and we'll have a pleasure of having a pic with them. And then, for those who are joining online, you would be sent in a PDF format. You can download that and print it for yourself for a display or use, whatever you want. So now we would take about 5 minutes break, and then I would be delivering a talk. So give me 5 minutes to prepare that stage, and we are shifting gears, and then we would continue to have talks till 5 o'clock with a break of lunch in between from 2 to 3. In case we have any positive patient, we see it now. And there were a couple of requests. So maybe I'll ask one patient after this talk that I would scan one patient and show you a couple of things like extended views, which we wanted, and there were more requests, and we would try to fulfill those, because Sunday we would not have normal patients, we would have more talks. We have called two or three positive patients with some minor abnormalities and some one major abnormality. So we'll scan those three or four patients, because Sunday we are not open. We've requested those patients, and they are likely to come tomorrow. So tomorrow there'll be just three, at the best four patients which we scan, and otherwise we would be doing finishing the lectures which we are pending.
Sorry, doubts.
I'll come. मैं उधर बाहर ही आ रहा हूँ. Hmm. So I think इसको we would table and this thing. Thank you. Are there some wheels missing here? Hmm. So yeah, question. वो एक बार वो I think it's recorded. You can listen to that. Maybe in case I get time, I'll show you. Sure.
Another thing, वो lateral view में drop out artifact आता है, beauty.
Camera ले.
And the other thing की like BSP are usually passing नीचे तो thing like that.
दोबारा. No, दोबारा. I was thinking something else. Please.
जब lateral view होता है, lateral view में LVOT जब हम खोलते हैं तो उसमें मतलब जो drop out आता है बीच
Yeah.
मतलब the other fact that VSDs are usually below the valve, not above the valve.
Yeah.
बस अगर आप
दोबारा कर देंगे. So this is out now, है ना? हाँ तो स्क्रीन शेयर बंद कर दें. बेटा नीचे उनको बोलना फीटल एक्रो में. पंकज किधर है?
रूम में
इसको हटा दो बेटा. It's unstable. It's not good. Remove it. Pankaj, tell them that we need one or two more patients. Normal. For showing some requests like extended. Give me a patient, those who have good window, so that I show them.
Excuse me, sir.
Yes.
सर थर्ड ट्रिमेस्टर में जैसे कोआक्टेशन एंड रेब्डोमायोमा के अलावा और कौन से लेट प्रेजेंटिंग कार्डियक एनोमलीज हैं सर?
Let me think about it and I'll answer. Okay. Abnormalities on the fetal heart would be yes, rhabdomyoma. Then many a times pericardial effusion, ductal restriction. I don't think so. Anything more? Can you guys think about something else?
Sir, can we miss
Coarctation, sorry, coarctation, the most important coarctation. That
So can we
manifests
miss
that.
TOF in second trimester and which develops later in third trimester?
No, the whatever developmental things have to happen, that happens at 5 to 6 weeks so of gestation. Then it persists. The anatomical things, DORVs, TGAs, TOF, and everything would happen in when the heart is developing, somewhere around 6-7 weeks of gestation.
Okay, sir. And sir, sinus venosus AST, does it have any significance in neonatal life? Or
No. Most of the ASDs are kind of operated in a preschool going age, so that's not very problematic. So we do not do ASD surgeries early. Sinus venosus in particular has a problem that most of the scandum ASDs can be managed by the device. Usually, sinus venosus ASDs, the surgery is required, but people are started doing intervention for sinus venosus ASDs as well. You can probably go to my YouTube channel. I think there is one video on sinus venosus ASD in adult section also. So there, the device closure I have described, which is, recently being done.
So I have one question.
Yeah.
Yesterday also and today also, there were more patients of ventricular disproportion. So right ventricles were enlarged and left down. इतना common है sir?
No, that's a referral bias. That is a referral bias because people would refer the patient with abnormalities to me. So that I think is a referral bias.
एक patient आपका refer किया था और eventually it turned out to be normal. उसमें भी ऐसा ही था sir.
Correct.
क्योंकि it was too early at 19 weeks. Eventually कहीं coaptation develop ना हो जाए तो मैंने आप पर
True.
No.
So I think we referral bias.
सबसे most common one of the most common cause है sir.
Ventricular disproportion. Yes.
के पास refer होते हैं इसके लिए.
Not really. That's not the commonest.
और कितने % केस इसमें normal भी निकलते हैं eventually?
Most of them.
So, sir, in today's patient, where RARP was slightly dilated, if all were to follow, what is to be mentioned in the report?
RARV PA larger than the left, but that's it. RARV larger. They are larger. That's it. Nothing beyond that.
We will not charging the patient, but 2 weeks follow up to buy or next week.
It's for learning also. Not right now. Maybe after 20 minutes. Up, keep. Don't stop. 10 minutes, 10, 15 minutes. You can start scanning and come back. Maybe not right now. I'm starting the lecture and then after that. Take about. So now these are the talks on. I would. You can't see that. Can you? I think you can. Online people cannot. Now we would start with the conotruncal abnormalities. Would that be okay? Or I think I'll start with the venous abnormalities and TAPVC. Hanji? Okay, I'll do it. I'll do it. Got your point. So is that good? So now we'll discuss this venous abnormalities. These are the common venous abnormalities which you would be looking for. Normally, you have right subclavian, right superior vena cava, brachiocephalic. Okay, and this is how brachiocephalic or a nominate vein, or you can have the left superior vena cava, and even in this pic, they have not removed brachiocephalic. You presume that presence of brachiocephalic rules out left superior vena cava, but that's not true. About 10 to 15% patients of persistent left superior vena cava would have a small brachiocephalic. So many a time that's the only the left one and not the right one. Very uncommon. And how do you see it? You see it in an additional vein in the on the left of the pulmonary artery. The left SVC on a three vessel trachea view is posterior to the superior vena cava, right sided. Normally, you see the aorta and the superior vena cava is just close to the anterior aspect because superior vena cava goes anteriorly to enter into the right atrium, while the left superior vena cava is posterior. Okay, it's little posterior. Don't expect it to be present at the same level. It is posterior. It is going posteriorly to enter into the mid of the heart, not the anterior of the heart, and where coronary sinus. Correct? So it is posterior. You would see left superior vena cava when you see the descending aorta. When you see the descending aorta, you make a little rightward sweep. Then you see the left superior vena cava opening into the dilated coronary sinus, what we call as that a cigar sign. I would show you. While the ascending aorta is seen when you see the right superior vena cava entering into the right atrium. And when we are talking about arrhythmias, what we do is that many a times we take SVC and aorta flow to diagnose arrhythmia. Aorta for systolic PET thing and SVC for atrial. So they are both lying together, ascending aorta. Descending aorta, left superior vena cava, ascending aorta is the right normal. And then you get dilated coronary sinus because it has to get dilated. And these are, common associations. We are not sure as yet because the literature is divided on presence of a coarctation of aorta with the left SVC. We think it's pure coincidence. And there are things which I think we would not the then for coarctation and left SVC, even left SVC can produce what we call as a ventricular disparity. The RA and RV are slightly larger. And the reason given for that is that when there is a dilated coronary sinus, it affects the fossa avalis streaming the blood to the left atrium. There is a very special streaming techniques through the fossa valis, the flap of fossa valis, and the eustachian valve. They kind of handpick the blood to go to the left atrium. This mechanism somehow does not work properly, so that the more blood goes to the right side, then would go on the left side. So you would get a marginal dilatation of a right side of the so that's another reason some people believe that a reduced flow across the left side can be the reason for association of a coarctation versus okay, so they think that probably that could also be causing some hemodynamic effect to have higher probability of a coarctation. So that's what is the theory. And you see there is a tricuspid regurgitation, the RARV are dilated, and Okay, and then you see there is one SVC here, and you see the other SVC there. So there are two SVCs, and okay, one SVC, another SVC. This is PA, which is larger, and aorta, which is smaller, with some diastolic hold. You always go frame by frame to see diastolic hold. You can put a pulse Doppler, but then you can see a diastolic hold. There's no systolic flow in the pulmonary artery. There's no systolic flow in the aorta. You just see the flow here in uh, okay, the isthmus, and that is what we call as a diastolic hold. Done? Okay. And these are the, associations, but more commonly, this is just associations, and I don't think so. We should be focusing our mind and on this. So then what you see here is what I was telling you. This is a trapezial trachea view. The normal SVC is anterior, and left SVC is posterior. And then you see this is the pulmonary artery, and that's an aorta. Okay. And this is a right-sided normal SVC. The other SVC is posterior to the aorta. This one is anterior to the aorta. And you see this azygos vein entering into the right. But let's skip this. And this is what many a time what we call as the cigar sign is when you see on a sagittal view, you focus on the left SVC. And how do you get this view is you go on a three-vessel trachea view, then get the left superior vena cava in the middle. Whatever structure you want to see in a longitudinal or a sagittal view, three-vessel view, you go to the three-vessel view, get the left SVC, in case you want to see left SVC or a right SVC, and then rotate 90 degree. Okay, you'll get the same structure in the longitudinal. So that's how you get the right SVC draining, a left SVC draining into the dilated coronary sinus, and this the right atrium. Right atrium and this structure put together makes it like a pipe, or make it like a, okay, right? That's how it looks like. And about 20% of them would have a small left brachiocephalic. So seeing brachiocephalic does not rule out the left SVC. So then you see the right atrium, the left atrium, and you see this coronary sinus, which is kind of looking normal. And those who were interested in appendages, now see that this is the appendage on the right side, which is again a kind of a finger-like and conical. It's like a beak of a bird, and this is left atrial appendage on the right side. So this was the patient of isomerism. Okay. So then you see this is the dilated coronary sinus in the cross section, and same dilated coronary section where you see the dilated coronary sinus, and you are sitting here and people are online. Guys, answer me whether this is a ostium primum ASD or it is a dilated coronary sinus. How do you differentiate? Color flow, that's what I didn't tell you. I told you something else. Maybe you didn't attend that. Yes, when
mitral valve is closed.
Yes, when you see the mitral valve is not opening well, you see the tricuspid opening well, that means you are not in the plane of the mitral valve. You are posterior to that. Okay, you move little anteriorly, you see both mitral and the tricuspid open, and that is where you see color flow is obviously one very good reason where you can see the color flow kind of bidirectional in primum ASD, and dilated coronary sinus would always be from the right to left side and a good flow, and 99.9% dilated coronary sinus is more likely than the primum ASD because that's extremely rare. Please, whenever see a dropout, rule out dilated coronary sinus before you commit that this is ostium primum ASD because that's far more common. So this is again that dilated coronary sinus. So again, we have this dilated coronary sinus, and it's obviously so because the tricuspid valve is opening, you don't see the mitral valve opening, and you have an RARV dilatation, minimal pericardial effusion, some cardiomegaly in this patient. And in this patient, you see this is descending aorta, and this is another vessel there. Why I say this is descending aorta? This is pulsatile. The other vessel is a vein. It's not as pulsatile. So then you see in an abdominal view, you see the vein lying just close to the aorta, and that means the IVC cannot lie posteriorly. If you remember IVC leaves aorta. Now, if you see the sagittal view, now IVC comes along with the aorta from caudal. Then when it comes and enters into the liver, it leaves aorta and makes an angle and goes anteriorly because RA is an anterior structure. So it goes anteriorly to enter into, right? So uh, the other vessel, a venous vessel, if it is inferior vena cava, one, that it should be on the right side. Two, that it should be anterior to the aorta. So if it is not anterior to the aorta, it's lying side by side. So this is not IVC. The IVC is interrupted, and this is continuation of azygos vein because the entire blood from the lower part of the body would be carried by the azygos vein into the superior vena cava. Okay, the entire flow goes into the superior vena cava. So there would be an interruption of IVC, and that's what you see as another vessel along there. And then you don't see IVC, you see these hepatic veins opening directly into a structure called vestibule. This portion where these veins are joining and then opening into the right atrium is called vestibule. It's a part of the IVC. The vestibule stays because embryologically it is from different area. The rest of the IVC is interrupted. So this is the only portion of IVC remains, and this helps you to tell that this structure where it is draining is right atrium. And then when you see the descending aorta, then you see this another vessel which is going in a different direction. It's going in an upward direction, while the aorta is going in a different direction, is going caudally. And this is the telltale sign of interruption of IVC, which is a telltale sign of left atrial aneurysm, isomerism. So this is again a congenital complete heart block, pericardial effusion, and then you see this kind of an appendage. And which kind of appendage is this? It looks like a right atrial appendage. It's little broad, and see the differences are too small. And this is a right atrial appendage because that's what we thought, that this should be a right isomerism. But no, this is a left atrial appendage. So that's why morphologies can be very deceptive. This is the patient of left isomerism. where you have a complete heart block, where you have an AVSD, and then you have this uh, interruption of IVC and continuation as an azygos vein. So we thought this is the right appendage. It's not. So please don't depend upon the appendage shape and size. You wanted to see it, I showed you.
There is a non-compaction.
Uh, Not really. Maybe you're right, but the both ventricles are, we're not sure which is right or left because that's not an appropriate view. And that again is not an appropriate view to say that this is non-compaction or not, because we are not truly at the apex. So this is a kind of an oblique view, like a short axis view of LV. Yeah, it's a balanced AVST. This is where you get an ASD. This is where you get an VSD. This is the common AV, but this part of the valve is atretic. You see, this part of the valve is not opening. So you can have a partial kind of atresia of one valve. Okay, and then the entire blood to this ventricle comes from this side. So this one valve is not opening, one side of the common AV valve. Okay, and many a times you see this structure and you make this URSA or something else. Okay, so this is not URSA. This is not coming from descending aorta. Many a time it does look like coming from the aorta, and you might think this is left. This is URSA, but it's not URSA because it's opening into superior vena cava. It's not going straight into the limb, right? And secondly, it's a venous flow. Your eyes should be trained to see venous flow with the two pulsatilities in the vein, single pulsatility in the artery. You can see the single pulsatility in the artery, and you see little stay in the vein, right? So this is an azygos vein. Many people call it as azygos arch. That's the third arch, right? Aortic, ductal, and azygos arch is just the name. Azygos is not going to become happy about it, but that's okay. We just don't need to name it. That's the thing what you need azygos, which is normal, and normal size should be less than 1/4 size of the aorta, because azygos and hemiazygos systems are developed to drain the venous flow from the chest cavity, not the lungs, but the chest. Is the hemiazygos and azygos drain the blood into the SVC.
Glass body surface area.
Pardon?
Glass body on surface area.
Yeah, sir. These are fancy things, and they are only to make look your presentation nice.
In normal is like this. ECG patients may be clear.
Yeah. It's a small vessel. It's a very small vessel. So majority, let's say, I would say, I mean, there's no data, but roughly 80% of the blood or 90% of the venous blood would be from superior vena cava and from the lower part of the body coming from the inferior vena cava. So only part from the chest, because chest is not a very structure where there are vascular. The pulmonary vein take their blood to the heart anyway, so lungs are out. Heart venous system is out. What you're left with, chest wall and intercostal muscles and stuff, that doesn't generate enough venous return. So they are generally very, very small. And if you talk about superior vena cava, that should be the largest vessel. The basic reason is not that it's area which is draining. The quantity of cardiac output going to the brain is far higher than going elsewhere. So that's why superior vena cava is generally larger than inferior vena cava, or same size. So ductus, I show you few because this is more of a fetal medicine or radiology talk. So I'm not going to, I'll show you only the shunts which are important for the heart. Rest I'm not going to show you all that. Oh, I thought I hidden those, but they're still existing. Okay, this is this one I wanted to show you. You see this uh, umbilical vein. It's not opening here in the inferior vena cava. It's opening here in the inferior vena cava, right? And opening here in the vena cava, right? So this is DVSS. In case it is associated with the, you get a ductus also, that is a different kind of DVSS. If it's open like a open channel without ductus there, then that's a different kind of DVSS, right? And DV is systemic shunt, ductus venosus systemic shunt, like UPS. Okay, so then this is umbilical vein opening into this, and that's the again another patient where it is opening into IVC, and that's what I wanted to tell you, that the IVC leaves the aorta from here. They kind of are together, and from here it leaves as it enters the liver, goes anteriorly to open into the left right atrium, which is anterior, the left atrium, which is posterior, right?
So the significant.
There would be no flow in the portal vein. There will be entirely going into uh, the IVC, inferior vena cava, and from inferior vena cava, as the hepatic veins open there, probably some flow would go there. I didn't think about it, so I do not know. None, 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 none. The liver and everything grows perfectly fine because you get a lot of portal blood coming to the liver anyway. Okay. And umbilical venous blood, most of it anyway goes to the DV out, but quite sizable amount. But we've not seen any patient of uh, hypoplasia of liver. Have you ever heard of hypoplasia of liver? Not compatible with life. Not com Liver is the organ which decides the growth of the entire body. Entire body. The morphogenetic factory is liver. So you would never see a patient with hypoplasia of the liver, right?
Is it a soft marker?
Pardon? Yeah, it's a soft marker. I mean, I'm not going to details of that. It is a soft marker. And one interesting thing which I saw in this video is the right lower pulmonary vein. You see this vein? Descending aorta. Okay. Yeah. So descending aorta, I'll stop this. Descending aorta and this vein, which is entering into the left atrium posterior, I told you. IVC is entering into right atrium. This is the left atrium. This blue one is the right atrium, the left atrium. This is the right atrium. And this is opening here into the left atrium. If this vein goes like this, that is what we call as scimitar syndrome. So you look for scimitar syndrome when you are having this view, where you see the descending aorta sagittal view and inferior vena cava. Okay, so this is where you look for normal right lower pulmonary vein and abnormal or PAPVC, which is called, it opens into the inferior vena cava or hepatic veins, and it is called the Schmittauer syndrome. Schmittauer is important. Schmittauer is important, is causing hypoplasia, one part of the lung, and then there are a lot of AV malformations or sequestration happening in the lung. That part of the lung, the right lung, it gets a systemic artery flow also. Sequestration means that you get aorta supplying that lung, apart from the pulmonary artery. So this shunting creates a bit of an issue, and the combination of these two are important for Schmittauer. Why I know all this about Schmittauer? Because I presented a video on Schmittauer. Okay, that was one of the self-inflicted CMEs, right? So C-Schmitter syndrome on isolate nothing. Apart from this, you should not be looking for any PAPVC. I have one case, but I deleted. I don't think so. We want to show it, and that's something which is abnormal. The DV directly entering the umbilical vein, directly entering into the right atrium. Now it is bypassing the DV. DV serves two purposes. One purpose is that it decides how much blood has to go to the liver and how much has to go to the heart. When you have patients with hypoxemia, DV dilates and it says let more blood or oxygenated blood go to the heart because that's where you need it more. You're already having hypoxemia, and less blood to the liver, and liver kind of suffers a damage. So that is one part of the DV. Second part of the DV, you have it works as a pressure gauge. It suddenly reduces the pressure of umbilical vein so that the LA and RA are able to take that pressure. Right? So this is second part. Now, if the DV is absent, you neither lost the pressure and you have a huge volume directly going to LA. The entire umbilical vein is going into the right atrium. So there's both pressure and a volume overload of the right atrium. And this can produce hemodynamic effects. Okay. This kind of DV absence can produce hemodynamic effects. So that's what I already told you, and I didn't forget to thank you. Okay, thank you very much for kind of uh, allowing me to have self-inflicted CME. No fund requirement, and the only and only agenda is me. Okay, so Pankaj, next. With this systemic veins. So there's one patient which is waiting, so I'll just do that and then we are good for that. We'll tell 10 minutes and then we'll talk TAPVC and then we go for lunch. And you can either have a coffee with the lunch, or you can have a small lunch, or you can have no lunch options if you want to remain awake. Okay. Pankaj, patient. इधर पेशेंट बैठे हुए ना, या बुला लो टेक्नीशियन, नीचे से बुला लो उनको, वो करें। ये केबल 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 पकड़, ये मैं करता हूँ, केबल केबल पकड़। Okay, so I think we have the screen share already. Okay, done. So we all set the mic. Okay. You can reduce the volume. I think it's high. Is that okay, guys? Leo. So we are good. Positive? हाय बेटा, बताइए क्या टेस्ट है इनका? ओके, लेवल 2 अभी होना। ओके, आई थिंक वी गो टू अगेन। So DV we have done, appendages we have done partly, and you wanted, okay, I remember, you wanted extended view. That was the most popular demand, right? So extended views, okay. So the trick, you are in now this kind of bradycardia and can happen if I apply little more pressure there, and that is normal phenomena. And we go to the 4-chamber view, and in case you are interested to see the arches, the best is that you are on the apex should be 3 o'clock, 4 o'clock position, or 2 o'clock, or other side 9 o'clock at this position where you get it better. You try to reduce this, and let me put the color Doppler on, and now I'm focusing on the descending aorta, and I'm getting it in the middle, and I'm rotating the probe now 90 degree to get uh, the aorta. Yeah, so that's an ascending aorta. I would have to make some adjustments to get a proper aortic arch. So give me some time because the baby is moved. Hmm. So in the meantime, all bicable view and 3 vessel, the baby is moved now. The apex is kind of down, and this is where getting the arches is becomes little challenging. The view where you get this is when apex and the heart is a lateral view, and then if you rotate, you are more likely to get uh, the arches. Here we can get the ductal arch, okay, and then let's try to do it with an aorta. Yeah, so that is what is an aortic arch, and that is one of the extended views what you see, and side by side reduce the depth slightly, okay, and then you can do all this fancy stuff, and so that is where, and it is so that is aorta, and I have to move on a slightly different direction to get the ductal arch. But anyway, we won't be able to get in the same position. I'll try and move the probe and take the ductal arch. Ductal arch is little more straight, and which I would tell you when I'm discussing, coming out and discussing with you. So that is one ductal arch which you wanted, and now you wanted a bicable view, and it's same at the almost the same level where you see this. And for bicable view, you have to reduce your neck width limit. And right now the back is in the front, so you won't see a very nice videos, the images, but still, yeah. So this is the inferior vena cava entering, and then you need to get the superior vena cava in a bicable view. Okay. Some movement with the baby, and I hope now we'll be able to get bicable views. That is a kind of a bicable view. Not a true bicable, but I think that's the better way we can get. This is the inferior vena cava, and that's the superior vena cava coming from there. But it's not as nice. So at least this is what we call as a maybe in the next patient when the spine is not up, we'll be able to see less of acoustic shadowing and more of the structures. But in the meantime, let me show you the LV and RV in the cross section. That is another extended view which is suggested. Okay, and then you are here at the LV. Acoustic window is not too good. You have next patient, Betty? No, the fetus has moved. That time it must be there. So now we started getting the apical view. Let's attempt there. That's an inferior vena cava. Right, so you see the superior vena cava there? And let's try both together. Yeah. So that is what is, yeah. Superior vena cava, RA and inferior vena cava. And here you would see the intraatrial septum or the tricuspid valve. Anyway, we'll try it in the next patient. Cross section, again, I think we'll try in the next, they will be able to get it here. Now this, with cross sections are taken in the, when the fetus is on the lateral, so the heart is on the lateral side, a lateral view, and then you rotate the probe to 90 degree to get the cross section of either side. You can do it clockwise or you can do it anti-clockwise, and this is what you get, the cross section of the heart. And the structure here is circle, and this is a kind of banana, and this is a RV, and this is LV, and you see this saucer and circle shape. Let me zoom it for you. And okay, so this is, and if you are lucky enough, then you can see the papillary muscles. I am not seeing the papillary muscles in this patient because of the acoustic window and gestation age. Then we would try it another thing, another patient. And this is where you get a cross section of LV and RV. And there you see the pulmonary artery coming out of the right ventricle. ठीक है बेटा, all good. We'll quickly scan another patient, and if we are able to get it, the bicaval view, we'll show you. So the issue is the things which you don't do so frequently, you are struggling. But if we include the bicaval view in all the patients, then maybe we would develop some quick fixes for that. But let me see in the next patient. Can you repeat the things which you wanted to see? Extended views was one. What else? I forget. हाँ जी बेटा, क्या इनका?
Systolic and diastolic function on M mode.
Hmm. Okay. No. Let's target that first because that's the lateral view. Zoom is very important there. You wanted an M mode, right? So zoom is a very important component of M mode. You should zoom the view. Uh, So most of the feti we examined today are awake and kicking. Cheek or whatever we got, we have a 2D clip, and then we go to the 2D clip and do an anatomical M mode. Okay. Okay. So you get this systolic and diastolic patterns. So now what we do is that take calculation here for the 2-point distance, and this is the diastolic measurement of left ventricle or right ventricle, and this is the systolic measurement of the right ventricle. So with these diameters, you can calculate fractional shortening. Let me check in case there is uh, something about fractional shortening. LV systole, four chamber, no. Anyway, I think we would search where I don't do it normally. So, but you can do a TAPSI and MAPSI. That I can tell you how to do it. That we do it, when it's required, but more in the adult echo than in the fetal heart. And TAPSI and MAPSI can be done on a 3D. Now this is the appropriate view. Okay. So now I save this image and go to this view. It is now this is the right ventricle wall in a extra zoomed view. Okay, and this is the tricuspid annulus. So I want to see the TAPSI. I put an anatomical M mode and I try to get this and put it on the heart, and then I go to cine. I scroll this up and down, and this is the best place where I get the TAPSI. And what is you watch this movement of the tricuspid annulus up and down as I scroll. You see this moving up and down as I scroll, and this is TAPSI. And how do you calculate TAPSI? Is that you go to 2-point distance, and then uh, from leading edge to leading edge, uh, I think it should have been angled, but that's fine. You can find out a way of doing it. Okay, so that is TAPSI. It's less than 2 is abnormal. It's 3.8 millimeters. Okay. So now So that is the inferior vena cava you see. And okay, this is the ductal arch, which is more straight. Put the color Doppler on for you. So that is the ductal arch, which is straight. Okay, the aortic arch, I'm not seeing it here, but it's more curved. And that's the ductal arch. Again, not a great window because the spine is anterior. Maybe we'll show tomorrow in that one of the positive cases what we see. We might be able to see it when the fetus is apex is. So that is the inferior vena cava you see. And then I'm not seeing the superior vena cava yet. And that's an aortic arch, which is more curved. Anyway, I don't think so. That struggle is worth it. We'll do it when it is seen very nicely. All okay, beta. All okay for you. Yes. Any quick questions? And then we are going to shift to the talks. I'll take a talk on TAPVC now. And maybe one more because TAPVC talk is not very long. And one more talk on conotruncal abnormalities. And maybe we'll start with the DORV or tetralogy of fellows. Mr. Pankaj, in the meantime, you can ask questions in case you have any.
Sir, when we do TAPS and MAPS,
For LV functions, LV and RV functions, they are not a very good method actually to assess the ventricular functions, but many a times that's the only thing what you have. Tie index is far better.
and sir, what is normal fraction shortening?
I forgot the figure because of fraction shortening less than 40, 35 is the cutoff.
Fraction shortening has significance.
No, I hardly use it. No. By the time I see fraction shortening bad, visually I see the ventricles are not good. It doesn't help. I'm interested that visually I'm not sure what it is, and then I need some support from my measurement to help me whether there is an LV dysfunction or RV dysfunction or not. Unfortunately, none of the techniques have really helped.
Again, question is that, sir, if there is a ventricular function abnormalities there, most of the time it is related to growth restriction only.
Many reasons for that. That's not the one reason. There are many reasons for that.
It is
Diabetes generally does not produce systolic dysfunction. It only produces left ventricular hypertrophy.
we will be discussing, sir, regarding this.
Ventricular function,
हमें फ्रैक्शन शॉर्टिंग सीखना चाहिए या टाइम इंडेक्स की तरफ
only tie index.
और उसमें abnormality आती है फिटल प्रोसेक्शन नहीं है तो हमें क्या सोचना चाहिए कि क्या हो सकता है बच्चे के को हम मतलब उसको काउंसल
The first thing, if you are doing a tie index and you don't see anything else abnormal, maybe verify your tie index. The very first thing would say you verify your technique. Are you correct or you're not correct? Once you've done that, then you look for that globular heart sphericity. These two would happen almost simultaneously. And then I don't find any disease where I would start hunting for something if I find an abnormal tie index. TIE index is a supportive thing for single ventricle kind of physiologies. TIE index is helpful in case the fourth chamber is looking normal, but it's globular, and that's what. TIE index had not been very helpful in decision making or making a diagnosis of any kind.
There mostly the cases are there is a structural abnormality in the heart. Then the time index will be
TIE index is only to prognosticate. But if you don't do TIE index, you won't be missing much. So don't worry.
And sir, we should routinely use radiant flow, or the without radiant also we can get most of information in color.
Most of information we can get it without radiant flow, and radiant flow gives you a little better fill, uh, and it's more fancy looking. I don't think so there is any other great advantage. We did find sometimes the pulmonary venous flow is seen little better with radiant. Many a time the VSD looks better with the radiant flow, and MRs and TRs are generally seen better on non-radiant flow than on radiant flow, because radiant flow kind of smoothens everything around the MR and TR, and we don't want anything to be smoothened around, except for the pulmonary veins. We don't mind. Yes, the pulse Doppler, power Doppler, and radiant flow would be helping you in the low flow situations, which I told you: VSD, pulmonary vein, and URSA.
And
Elazing,
sir, yes, sir.
sorry, let me. Elazing is not seen very nicely with the radiant flow. If you are interested to see elazing, to please put off the radiant flow. Yes,
And sir, how are Samsung ultrasound machines for fetal echo?
I use Samsung for at least 5, 6 years.
Okay, sir.
Wonderful machine. Now I'm using GE,
Samsung.
Samsung WS8, WS80 is it called, right? WS80, not RS80, WS80. Very good 2D. But as I told you, this is like AI. Somebody has some improvement, the others are so quick to copy, right? So, couple of things which were there in pardon? Siemens, I don't have any experience. Did you ask about Siemens?
No, sir, reverberation.
Refurbished machines.
No, sir, my voice is reverberating. So,
I was thinking on fetal echo only. Okay, fine. My bad. Right. Tell me. Your
yes,
voice
sir, that's it. Thank you, sir.
is vibrating because you are using probably two devices with you. It only
Yes,
reverberates at your end, not at mine.
yes, sir.
The issue is at your end. You have to mute one of the devices, and then that's why the guys were asking, are you tech savvy? You got to be. Because
Yes.
by now, I think I have done about 150 webinars, maybe more. In COVID only, I did 60. That's how I remember. So, so once you keep doing webinars, and then yeah, these things can go wrong. But there are always surprises still, despite you being smart enough. You still learn new things. And that's always said that why make an old mistake when you always can make a new one? Okay. So And all of you are okay on site online? Okay. Now, total anomalous pulmonary venous drainage. Again, an abnormality you hunt for. Hunt for this because it's too subtle. And normally the pulmonary veins enter into the left atrium, and we have lot of variations there. About 20% times you'll get three right pulmonary veins, a separate pulmonary vein for a middle lobe of the right lung, which is a trilobed, and many times the left ones can fuse together and join as one. So you can have between 3 to 5 normal pulmonary veins. So TAPVC is divided into three. What is TAPVC? Total anomalous pulmonary venous connection. We prefer TAPVD, that is drainage. Okay, there could be a connection, but they may not be draining there, but that's too uncommon, too rare. But once you are correcting your nomenclature, it should be drainage. So now once we talk about drainage, then normally what happens when embryologically the pulmonary veins develop from the lung buds. Okay, and there is a left atrium, and the pulmonary veins join to form a common chamber. That common chamber connects with the right atrium, and its walls get absorbed. So all pulmonary veins opening into the common chamber, then it enters into the left atrium, and left atrium eats away the walls of the connection between common chamber and that, so that pulmonary veins, rather than opening into the common chamber, now they separately open into the. Okay, so that again is a theory of where is this chamber, the posterior chamber and the LA border. Where does it start in a normal person is where you get chordatum sinister. So you see the chordatum's membrane, the chordatum membrane, where the membrane which divides the left atrium into two, that is just proximal to the left atrial appendage. So a part of the left atrium is of left atrial appendage, which is quite lying on the distal part. So that part of the left atrium is true left atrium. Rest, what atrium, left atrium you see is the common chamber which has been absorbed, or a common venous chamber which has been absorbed into the left atrium. So many a times that chamber does not get absorbed. Okay, so now pulmonary veins open into that chamber. Okay, and that chamber opens into the left atrium. But now what we have is a chordatum. You see the membrane. It did not get absorbed. You getting my point? So now, if you have that which is not absorbed, but the pulmonary veins not drain into the left atrium, that chamber decides to drain somewhere else. That is which becomes a total anomalous pulmonary venous, that the posterior chamber was unable to form a connection between the left atrium. All pulmonary veins drain there. Now the veins are coming. They find some vein which was supposed to disappear, but embryologically, but still continues and drains at various places. If all the chambers connect together and the drainage happens supracardiacally, it is supracardiac TPVC, it can drain into the brachiocephalic vein. It can drain into the superior vena cava. Okay, rarely the azygos vein. right? The most common drainage of that chamber is into the brachiocephalic. And how does it drain? It drains through a connecting vein, which we call as a vertical vein. Whether it goes up or down, it's called a vertical vein. So now this chamber, all pulmonary veins draining there, forming a chamber here, and then you get a vertical vein draining. So the vertical vein, where does it drain, decides that which type of TAPVC is it. Now the next this is the rarest cardiac TAPVC. Number 2 is a infracardiac TAPVC. Supracardiac TAPVC generally happens without any association, while the infracardiac TAPVCs are commonly associated with the isomerisms. TAPVC is practically present in about 80% of the isomerisms. Very high likely. So then TAPVC, both left and right. Okay. So the least common is cardiac type, where the pulmonary veins drain directly. Water bottle then, very water bottle can drain directly into the right atrium. How? The posterior chamber gets absorbed in the right atrium. So now they open, thank you. They open separately into the right atrium instead of left one. Done. So the next common is that is the rarest, and then you have the common chamber through a vein, which is actually not vertical here, but through the vein called a vertical vein, opens into one end of the coronary sinus. Okay, and the coronary sinus, which is sealed from the left atrium, goes and drains into the right atrium. Whichever way pulmonary veins, if they finally enter into the left atrium, that's not TAPVC. We have never seen, let's presume if there was a vertical vein and opened into the left atrium, this is not TAPVC. They went where they wanted to. So now the next question is the infracardiac, where again the pulmonary veins meet. You have a common chamber, then you have a vertical vein which goes through the diaphragm, through the hiatus, where the esophagus goes, where the descending aorta goes. Anything? Yeah.
Sorry.
Yeah. So then the mixed type, a few pulmonary veins can open into the one side, let's say into the right atrium, other can go supracardiac, few can open infracardiac, and can open into the cardiac. So this is mixture. But mixture again, all pulmonary vein has to drain elsewhere than left atrium to call it total anomalous pulmonary. If two veins open somewhere else, and that would be still a partial anomalous, PAPVC. It would not qualify for TAPVC. So what are the signs? Why, we are looking for signs? The problem is, normally the pulmonary veins, imagine opening here and going here, right? And we see the pulmonary vein is opening into the left atrium. When you have a posterior chamber, pulmonary vein is coming here and opening into the posterior chamber, coming here and opening into the posterior chamber. How do you recognize this is a posterior chamber? There is a membrane separating the LA and the posterior chamber, right? If you do not see that membrane, particularly once you put on the color Doppler and you do not have side-by-side 2D, the color information which is coming from the pulmonary vein would possibly spill over on that structure and would be masked. Agreed? So that's why you have to do a 2D, and then because of the resolution issues, we decided that we should depend more on indirect signs than depending upon the direct signs opening there. That's why the surgeons of indirect signs came. The index sign was normally the pulmonary veins anchor the left atrium posteriorly. Now that anchor is gone, the tent is free and it moves little anterior. Moreover, you do need some space here for the posterior chamber or common venous chamber. So if you are able to place another aorta here, that means the distance between the aorta and left posterior atrial wall is the sensitivity and specificity of the sign is more than 95%. Very good sign. Very, very reliable, provided you see two ribs like this and you are not angled. I have seen the gap increased. I did not report. Gap increased in CPAM or CCAM. When you have the lungs which are hyperinflated, so I have documented increased distance between aorta and LA wall with no TAPVC. Okay. So CCAM of the left side. So then is the twig sign. Twig sign is nothing. The posterior chamber is seen like a twig. That's what is a twig sign. It's seen like a twig. Another sign is that no vessel or a vein is supposed to cross in front of the aorta. If it does cross in front of the aorta, either pulmonary vein crosses the aorta and goes on the other side. This is TAPVC. The pulmonary vein should respect the anterior aspect of aorta, open here and open here, not cross the aorta and go on the other side. So these are indirect signs which are good to look for. Again, I would request, hunt for these. These signs are also too subtle to be picked up on a routine scanning. So showing you the signs. Another sign is a bald left atrium or a rounded left atrium. Left atrium is never like this. It's boxy, right? Like a box, because the pulmonary veins are pulling that posterior part down. And this is one. Second, you see the increased distance, aorta and left posterior wall. And then what you see is this twig sign. Twig sign is what? This is the posterior chamber. Other signs are you find an RARV dilated, you look for TAPVC, dilated coronary sinus, and you don't find left SVC. The very first hit should be that is it pulmonary veins entering into, and then you see another vein in the three vessel trachea view, which is not left superior vena cava, but the direction of the blood is in the superior vena cava. Blood goes one direction toward the heart, and this goes away from the heart. Adult cardiology, we know once you are doing a suprasternal view, there is any venous blood flow going away from the heart is a TAPVC. Okay. So venous blood cannot go away from the heart. It's supposed to go to the heart. Left vein with increased flow, you see, you don't see the direction. You see left superior vena cava, or you see the right superior vena cava. The brachiocephalic should be small, correct? But instead, brachiocephalic is large. Okay, it's large because this is not the left superior vena cava. This is the vertical vein which is entering into brachiocephalic. Okay, so these are again soft clues. Fossa valis, which is not bulging to the left side. Pulmonary veins are not entering into the left side, so it's bulging more to the left. As they are entering into the right, and it's producing an aneurysmal dilated inferior vena cava. One of the reasons of dilated inferior vena cava or superior vena cava is TAPVC entering into respective vein. There is something called the Coumadin ridge. We adult cardiologists, when we did a transesophageal echo, we found this kind of ridge and a blob there, and we thought it's a thrombus, and we started giving Coumadin. Later, we realized this was not thrombus, this was a ridge, and then we named that ridge as Coumadin ridge. Okay. So this is just an invagination inside, left atrial appendage going out, and this is an invagination between left upper pulmonary vein and left atrial appendage, and this forms the ridge. Now, ridges are seen so nicely on a fetal echo. This can be used as another indirect sign to rule out TAPVC. This is not to rule in TAPVC, this is to rule out TAPVC. If you see the ridge, that means one pulmonary vein is entering into the left atrium, and that means it is not a total anomalous pulmonary venous drainage. So that's how the ridge is formed. And we did a small study to say, which we presented in Vienna, ISOG, that how long does it take from a good four-chamber view? You have to get a good four-chamber view. You might struggle for some time to find a Coumadin ridge, and in what percentage we could see it normal. So the average time was about 45 to 50 seconds. Once you have a good view, you move this side, that side, and you were able to, if you don't get a four-chamber view, you would not get Coumadin ridge. So after good four-chamber view, it was less than a minute that we were able to pick up the Coumadin ridge, and we were able to pick up Coumadin ridge in about 95% of the patients. I think we did around 200 odd patients, normal people. So that's the Coumadin ridge, and that's the Coumadin ridge. This you saw today. Exactly the lateral view. You saw the atrial appendage, and you saw the pulmonary vein, and you saw the ridge in between. And you can confirm this is the pulmonary vein, and that's the ridge, and that is the left atrial appendage, which is not showing any significant amount of flow to and fro. Let's talk about supracardiac TAPVC and show you a couple of cases. And this is what happens. Supracardiac TAPVC, now the blood goes from both the pulmonary veins into posterior chamber, into vertical vein, brachiocephalic and superior vena cava, and into right atrium, not the destination where it is supposed to reach. Here, in case it's reaching superior vena cava, and when the child is born, in case you get an ASD, gets closed, like PDA get closed after birth. If the ASD gets, or the fossa vallis get closed, that produces an obstruction. So what it's going to do? It is going to behave like mitral stenosis, tight mitral stenosis. All pulmonary veins opening, and they want to enter into a left atrium, and there's an obstruction there. It is the obstructed TAPVC becomes obstructed. The moment the pulmonary veins become obstructed, they produce pulmonary edema. The pulmonary venous pressures go higher than the oncotic pressure, and then the fluid starts exuding into the interalveolar spaces. And that's what is pulmonary edema. So pulmonary edema, so whenever you have a supracardiac TAPVC, infracardiac TAPVC, it's wise that patient delivery is done in a tertiary care unit, because likelihood of getting obstruction is there even in the supracardiac TAPVC, when it is normally the vertical vein gets obstructed. But here, without obstruction of the vertical vein, also you can have another obstruction when the child is born. So this is the patient where you see, this is a still image, this is left ventricle, this is the right ventricle, Right ventricle is dilated, RA is dilated, LA is normal size, but there is some suspicion of pulmonary vein here, but it's more of a rounded than otherwise. But then you see this twig sign behind the left atrium, and you see this stupid vein crossing in front of the aorta, right? And then it becomes almost a sure sign that this is a TAPVC. So now this is step one. When you see the twig sign, when you see the pulmonary vein entering into the posterior chamber, that is step one of diagnosis of TAPVC. Step two is where it is draining. And step three, is it obstructed or not? So there are three steps. So then you have this vertical vein. Again, no vein is supposed to go away from the heart. This vein going away from the heart and would open eventually into brachiocephalic and then SVC, right? So this is a vertical vein, and you can confirm that vertical vein without obstruction so that you would be able to get the normal venous flow. If it is obstructed, at the level of obstruction, you would have higher velocities, more than centimeter, more than 1 meter per second, and this would become flat. The pulsatility of the pulmonary vein is gone. So wherever you put the sample in the pulmonary vein, you get a continuous flow like your umbilical vein, right? So again, the fancy 3D. Now, this is, many people call it figure of 8, 1 and this. Anyway, left pulmonary veins, right pulmonary veins, opening into vertical vein, brachiocephalic and SVC, and it does run. Okay, the pulsatile flows you see of aorta and the pulmonary artery, right? So this is the right pulmonary artery side going, but background you see continuous flow, left pulmonary vein entering into the vertical vein and brachiocephalic, and that's what is the TAPVC. Now we talk about infracardiac TAPVC. Uncommon and very few cases. I think I've seen about 3 or 4, not more. And then again the twig sign, the first step of TAPVC. Then you find out there is no vertical vein, there is no another vein in the. That's how the easy trick is. Don't do anything. Just the commonest thing is supracardiac, right? Go to 3-vessel trachea view. You find a dilated brachiocephalic, dilated SVC, and another vein. Oh yeah, this is supracardiac. Then you trace the vertical vein, go oblique, whatever, right? If you don't find it there, oh, it is not there. Second step, I would maybe look at the coronary sinus. No, the coronary sinus is not dilated. So I have left with two conditions which are uncommon. One is the veins directly opening into the right atrium, or I'm talking about an infracardiac TAPVC. Right. So once you see that, then you go to do you see this is the aorta, and this is the venous flow which is supposed to go toward the heart. The venous flow going away from the heart is abnormal. It is going away from the heart. And that venous flow was opening into one of the hepatic veins. And that is a flow which is kind of a continuous. And the flow was continuous without phasicity because there was an obstruction. The infracardiac TAPVCs are almost always obstructed. Site of obstruction is the hiatus, where it actually opens. Okay, so that's again the twig sign. And then again, you see this is the supracardiac vein, but I think leave that. So supracardiac TAPVC, the obstruction can happen when it crosses the pulmonary artery and the trachea, that is where the obstruction can happen in supracardiac in fetal life. When the child is born, the pulmonary artery suddenly grows big, and if there was no obstruction seen there, now you'll start seeing the obstruction. Okay, so supracardiac can get obstructed with this. There's no evidence of obstruction in the fetal life, but at the level of pulmonary artery, where it crosses, or at the level of fossa valis. So two places, even normally non-obstructive looking TAPVC can get obstructed. And this is the infracardiac which gets obstructed. Supracardiac with small number would get obstructed. Cardiac would never be obstructed ever. And infracardiac almost always obstructed. Now let me show you a case or two of intracardiac TAPVC, and then we break for lunch, maybe an early lunch, or maybe I'll keep you awake with some one interesting book discussion. Is that I went to Srinagar. I was supposed to deliver this kind of workshop. So many reasons I would not quote. The numbers were small. The guy was smart. He knew the civil surgeon of Srinagar. He requested civil surgeon that please send somebody, but there is an adult echo class going on. So he sent all his the MD medicine people, interested or not interested, please go and attend, and your attendance would be marked even if you are not coming here. So that kind of power that guy had. It happened. The people came. I learned about it 2 days before. This is going to happen. I said, this is a challenge. There is somebody from Assam who has traveled to learn adult echo. And there are people, those who don't want to learn anything. So where do I keep the balance? Right? So I continued to think about it. I found a solution. Then in between the slides, I would show them my bookshelf, the books which changed my life. So that kept them interesting. So they would sleep in between, and then I showed them bookshelf, everybody's awake. Something is going on. So that is what the trick, and I still use that trick occasionally. Who is sleeping anyway. So I'll keep everybody awake. That is the agenda. I remember in PGI, there was a session going on, and everybody was awake, and suddenly we hear loud snoring at the back end. So it was more audio response of sleeping than otherwise. And that's a dilated coronary sinus. Okay. Then once you see the dilated coronary sinus, you see there's no SVC, left SVC, right? Then what do we do? Sorry, this is labeled wrong. This is trachea, this is SVC. So I'll correct that. Okay, so then you find something here. You find pulmonary veins entering into the coronary sinus. This is very lucky hit. You don't get this very easily. This we got after about an hour of struggle, but we knew this. So then this is what you get. Normally, one pulmonary vein, and you see this structure. Here you could not make, it's going to the coronary sinus, right? And this was better. There was a 2D along with this. I cropped it because, and then we did a three-dimensional fancy show. The coronary, you could see crossing in front of the aorta, one vessel and another vessel, pulmonary vein, opening into the coronary sinus, finally opening into the right atrium. Oh, that sequence is a little off. Anyway, I'll stop this. So that is the same patient. Pulmonary veins opening into the coronary sinus, it was not very clear. Again, a pulmonary vein opening. Now I'll stop it here and show you, yeah. Now you see this coronary sinus and you see this pulmonary vein opening into the coronary. Yeah, can you see this coronary sinus here? See the coronary sinus and the pulmonary vein opening into it. And this needs a lot of struggle. Okay. But if you see dilated coronary sinus and you do not see left SVC and you have a strong suspicion of TAPVC, twig sign, and then it's coronary sinus, even if you are unable to document the pulmonary vein entering into. So thank you very much. Before we disperse, any questions first?
Sir, is there a size cutoff to label coronary sinus is dilated?
Yes, 2 millimeter. There is a nomogram also available, but usually we take 2 millimeter as a cutoff.
Okay, sir. Thank you, sir.
Sir, what was the follow of the last case where pulmonary veins were draining into coronary sinus?
Yeah, the delivery was done in a tertiary care hospital, and the surgery was done when the child was about a month old.
Okay, sir. So it has a better prognosis, sir? Or
All the prognoses are same. For surgeon, it's very easy. I ask the surgeon, TAPVC, sir, infracardiac, sir, supracardiac. He said, shut up. I know what to do. There is a posterior chamber. I just have to open that posterior chamber. And that's it. And tie the vertical vein. Wherever it goes, I don't give damn to it. So I just open the posterior chamber is already lying there. You just open the wall of LA. So it's that simple. So that's the outcome of, and that explains the prognosis in that patient. So anything from you?
Every time we have to do the velocities for a vertical vein,
it becomes obvious. Then you get a lasing there. It really becomes obvious. But then you put the sample volume there and see whether it's obstructive. See, the issue is whether obstructive or not obstructive. You anyway would have to, tell the child to be born in the tertiary care unit. They can happen later, right?
certain cases, but you have said that people will get hypertension to those pulmonary edema हो जाएगा.
After birth. After birth. After birth.
Obstructive भी हो तो भी
After. Prenatally नहीं होगा कुछ कुछ. No.
Sir, I had a case of a persistent SPC and dilated pulmonary sites.
Mm-hmm.
Both the report and discussed with the academics. So after discussing, they were more apprehensive to how to proceed further. So what all
Left SVC. No, nothing is required. Left SVC, you don't need anything. You maybe ask them, you can screen the patient to look for coarctation of aorta. That's what you follow up around 30 weeks or you look for a coarctation of aorta. If it is not, then it's perfectly safe, right? Unfortunate to make a statement, but I've seen termination of pregnancy with the echogenic focus in LV. Unfortunately, we don't have a standardized Medicare in India. There are all different levels. Jawaharlal Nehru once said that in India, jet age and stone age would coexist. And that's exactly what is happening now. You still have places where they do not know who is the prime minister of the country. Despite our prime minister made a lot of effort, even on Atta Dal and everything, even on your vaccination. अब सबको पता होगा. Everybody is in jet age today. Is that? So before we go, should we discuss? I think I'll discuss the book later. Because after food, you're going to be a little groggy. Discussing book would be more interesting when I keep that reserve. I keep reserve 2 books. Yeah. नीचे आ जाना करने. I, I want to scan. Okay, we'll scan another patient about 15 minutes. Let's stick to time. Okay. So we'll discuss 2 books. One minute. आ जाओ लेटाओ. 1 minute manager meets monkeys. And they know, I've told them. Second is you can negotiate anything. That would help you to negotiate the equipment. Unfortunately, the GE guys listen to that talk. It's on YouTube. And they say that we know now. I said, बिल्ली में ट्री के ऊपर चढ़ना नहीं सिखाया था, बाकी शेर को सब कुछ सिखा दिया था. अभी वो है मेरे पास. चल, let's do it.
So much of non-fiction mixing.
It's very important. It's very, life at large is more important. Profession is one part of your life.
But means mostly read non-fiction.
No, I read non-fiction because fiction, I mean, it depends. I mean, I think it's more of a gender specific. So,
Yes, sir. So our bookshelf
you-
is one this side. I am reading all the fiction books. My husband is reading all
on non-fiction, I think it's more of a gender issue than anything else. Many of you are fond of gossips and this thing, and that is reading gossip. Fiction is so it improves your ability with the non-fiction books. It really raises your ability. I've read many, and they've been very helpful in my. But I'll share 2 with you. Hmm. Achha, okay. कैमरा रहने देते हैं. ओके, पोजीशन देख लेते हैं in case it is there. Are we on? We have a 16 weeks gestation, and I'm not sure the position is good or not, but we'll attempt that. Hello. Hello. Okay. The camera off, है ना? So there's no camera. Okay. Go to first semester first, I think. अभी नॉइस आ रही है कुछ?
दोनों माइक कंट्रोल है, नॉइस पर.
Okay. Now this. Okay. So again, start with an abdominal view. And the fetus again is moving. So then you don't have to wait. Many times you can scan the fetus when it's moving, have a rough idea, and then wait for some time. As the gestation is about 16 weeks, the Nyquist limits are going to be different. Your Nyquist limits are far lower than you would have in 20 weeks or 30 weeks, where the velocities tend to increase as the gestation grows. So here you will keep the velocities low. side by side. You get 4-chamber view looks okay. The LVOT is fine. Let's do the Doppler of LVOT. And there is a mild tricuspid regurgitation here. You see this? This is a mild regurgitation, which is insignificant. These are of no consequence. They keep coming and going. So not important at all. But even if the fetus is moving, let me try to capture that TR jet. Yeah, so that's the TR which you saw. Fine. So as the fetus is small, we'll focus on the maximum zoom. Then you see the pulmonary veins. The distance is not increased, so that is all normal. You see the pulmonary veins, and you increase your this, you reduce your filters, and then you see the nice pulmonary veins even in 16 weeks. So not a very big problem. You go and increase Nyquist limit. You go and see the RVOT view, and you see the pulmonary artery bifurcating. Great. And then we go a little more cranial to get a 3-vessel trachea view. And then you get this trachea and 2 vessels. You hunt for the URSA, and then maybe you try, and that's the artery which was going anterior to the trachea, so URSA is kind of ruled out. Second thing, what you need to hunt is for the VSD, the muscular one. So I now look at the frame rate. I've gone to the frame rate of 190. So that is what was required for 16 weeks gestation. If the frame rate is high, it could actually reduce the resolution. Okay, so now I do it with the color Doppler, and muscular VSD is going to be a big challenge here. And then I have a no Nyquist limit and go side by side 2D. I reduce the gains till I start seeing the septum again, and I don't see any flow traversing the septum and going on any side. So essentially, this is normal scan. All right.
I just needed your advice. My diabetic and asking specifically पे आपसे पूछूं, what should be the frequency of my, क्योंकि वो कहते थे कि there's a chance of these antibodies passing the placenta between 16 and 26 weeks.
Okay, wait for a minute. Okay. So what you have SLE
So,
documented?
no, sir, I don't have any history of SLE. I took an ANA profile test.
Uh-huh.
So उसमें I tested strongly positive for RO52 antibodies and positive for central
LA,
SSA.
SSA, both are there. Okay, so now we should start screening the fetus at 18 weeks and do a 2 weekly, two weekly till about 28 weeks. If nothing has happened till 28 weeks, nothing would happen there later. So that's how, and we do it with the PR interval.
Okay.
So I'll just check the PR interval now
Right.
and document it, and then we would have to follow up with the PR interval as we go.
104.
104. Okay, we'll check it again here. You done with the other machine? Now we'll do it here again. Okay. You have a previous babies?
No, sir. My first.
Okay. Done. Okay, we would do it here. All right, and we increase the speed and then we reduce the gain. We always tend to reduce the gain, and then we calculate the PR interval. And here the PR interval, onset of the P wave to the onset of this is about 113. So it's variable, varies with the heart rate. Previous measurement was 106, 104, and then it's 116, 13. Less than 130, we don't need to worry. We scan little more frequently. If it has been 130 to 150, 160 and 70 above, we get worried. So we have good range. All right. So we have a distinct advantage in Chandigarh. We get a lot of aware patients, fully aware, right? But I suggest you don't Google,
So I'm not Googling that.
and only in case you have to search, do ChatGPT. Okay,
Thank you, sir.
right. Any questions, beta? Anybody on online? And right, beta. Take care. See you after 2 weeks.
Sir, what was the history of the patient?
The patient, I don't know why, it got an ANA done, and then got a profile of and there was anti-RO and anti-LA, SSB and SSA antibodies. That's what we call them now. And they were elevated. They were increased. So there is a suspicion of a subclinical SLE or something, which is not manifesting right now. Then the concern is, if you had anti-LA, anti-RO antibodies positive, then you should look for a development of a complete heart block, and then we can monitor by PR interval. We hope that complete heart block takes time from the PR interval prolongation to its development. It doesn't happen suddenly, but then we monitor the PR interval, and when there is a prolongation of the PR interval, then we give steroids. At this point, when the pregnancy is there, the HCQ does not, hydroxychloroquine does not help. It helps before the pregnancy. So if the patient was not on HCQ, if you get a PR interval prolongation or 2:1 AV block, we give steroids. If we get a complete heart block, nothing works. Then we follow them periodically till 28 weeks of gestation to look for that. And if you ask me what is the incidence of SLE or anti-RO, anti-LA antibodies present of causing a complete heart block, is less than 2%. Okay, so it's not very high anyway. Anything more? So today we got another case which we discussed, right? I have a special talk on anti-RO, anti-LA antibodies, and I will touch that when we discuss it. Mild TR, mild TR has significance, but not in this case. But in case the pregnancy is little more advanced, then yes, I think we've done. So I'll stop the webinar after some time, after question answer session is gone, and then save that recording, I hope. And then in case there is TR after 24, 25 weeks of gestation, and you get some echogenicity in the heart, then we know the anti-RO, anti-LA antibodies do not only affect the AV node, they affect the myocardium as well. and they also affect the sinus node also partly, very small. So just sinus bradycardia could be a sign of anti-RO. Rarely though, but it could be a sign. But they affect the myocardium, producing myocardial dysfunction. They affect the endocardium, producing valvopathies, mitral tricuspid regurgitation, rupture of the cardi also has been documented in this. So there are a lot of things, extra nodal effects of autoimmune heart disease. That's what is the, but we'll discuss. I have a slide on that.
So what was the heartbeat rate at which we should be careful by like it's
It's coming. There are the nomograms available, but I have that included in the talk, so we'll show you. So lunchtime, 2 o'clock sharp, 3 o'clock, eat less, and remain awake. Though some people can